Selamat pagi, Pak Aryo.
Selamat pagi, Dokter Eva.
Apa kabar hari ini?
Alhamdulillah baik, Dokter Eva. Akhirnya bertemu.
Nice to meet you.
Terima kasih. Nice to meet you too, Dokter Eva.
Nice.
So, you are living in Bali?
I am, yes, yes, yes.
Oh, ya, ya, ya.
Udah lama ya.
Udah lama.
Yeah. I just sent you a WhatsApp.
Ya,
Yeah, if you
ya, ya.
can reply, we don't have to discuss in just let me know if it's okay.
Oke.
Take
I'll
your
check.
time. Yeah,
Ya.
yeah, pelan-pelan.
Pagi Bu Eva, Pak Aryo.
Pagi,
Pagi,
Bu
Dokter
Sri.
Sri.
Apa kabar?
Kabar baik. Belum sehat ya?
Extra early.
Ya, oke.
Thank you.
Kita buka, Bu Eva, Pak Aryo, teman-teman sekalian.
Siap, siap.
Ya, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi pada teman-teman sekalian, terutama narasumber Bu Eva dan moderator kita Pak Aryo. Pagi ini akan kita ikuti bersama workshop 3-in-1 program pada sesi terakhir dari seluruh rangkaian kegiatan dari 2 kali pertemuan lecture dan 2 kali yang terakhir ini adalah workshop. Meskipun nanti Bu Eva akan memberikan beberapa hal tentang practical skill in dementia care, assessment communication and non-pharmacological interventions, tetapi dengan berbesar hati Bu Eva akan juga menerima pertanyaan tentang aspek praktis bagaimana untuk teman-teman mengkondak penelitian kualitatif. Jadi program ini adalah rangkaian dari hibah 3-in-1 program yang mendatangkan lecture internasional dan praktisi internasional dan dalam negeri. Terutama adalah tema tentang qualitative research dalam hal kita memperbaiki publikasi dan kualitas penelitian kualitatif terutama pada setting long term care. Yang merupakan salah satu mata kuliah elektif dari PPDS 1 Ilmu Penyakit Dalam. Bersama kita semua ada Bu Eva dan ada Pak Aryo, mohon maaf. Kemudian ada 2 workshop, yang pertama nanti Bu Eva dan berikutnya adalah Dr. Tita. Untuk memperlancar kegiatan pagi ini, mari kita buka bersama dengan berdoa. Berdoa dipersilakan. Berdoa bisa diakhiri. Kami persilakan Pak Aryo untuk leading workshop pagi ini. Kami serahkan Pak waktunya.
Baik, terima kasih Dr. Sri Sunarti. Terima kasih Dr. Eva. Terima kasih semua para partisipan yang telah hadir pada hari ini. Sebenarnya saya baru tahu Dr. Eva ini tinggal di Bali ternyata sudah lama. Dan she speak bahasa Indonesia very well. And I prepare a moderator script in bahasa Inggris, Bu Sri Sunarti. But I will try to speak in English. Baik, Assalamualaikum warahmatullahi wabarakatuh. Good morning, Bapak dan Ibu. Today we will have 2 topics which will be delivered by first speaker is Dr. Eva S. van der Ploeg, and the second is Dr. Tita Haryanti, MKes. Before we begin the first topic, please allow me to introduce our first speaker. And maybe some of you may already know Dr. Eva, as she was with us before in her previous class last week. But for those who may not have attended the class before, let me brief introduce our speaker today. Dr. Eva is a research psychologist with a PhD in public health from Erasmus University, with a lot of experience in both research and practice. She has worked with leading institutions in Australia and Netherlands, including Monash University and Leiden University Medical Center. More recently, her studies also focus on dementia care in Indonesia, exploring care network, awareness, and perception of dementia. Beyond her academic work, Dr. Eva also published widely in her field. She also worked as a practitioner and trainer in Montessori for dementia, Namaste care, and mindfulness. This shows her commitment to connecting scientific evidence with real-world practice. So, once again, it's a pleasure to have Dr. Eva with us today. Dr. Eva will share her expertise on practical skill in dementia care, assessment, communication, and non-pharmacological intervention. And ladies and gentlemen, Bapak dan Ibu, please welcome Dr. Eva S. van der Ploeg. And Dr. Eva, the time is yours. Silakan Dr. Eva.
Thank you so much. Terima kasih banyak. Good morning, everyone. Selamat pagi. Assalamualaikum. Om Swastiastu from Denpasar. And thank you so much for catering for me in the English language. As much as I understand Bahasa and speak it a little bit, it's so much more comfortable, especially in my work field, to speak in English. So thank you. And also for preparing in English. I really appreciate it. Also, thank you again to Ibu Sri for hosting me and helping me kind of shape this workshop today. So, Pa Aryo, if you can let me share my screen as well, I will start the presentation.
Yeah, please.
Let me check if it's working. Perfect. Here we go. Take a moment. Is this visible, Pa Aryo, or? Yeah.
Yes.
Okay.
Yes.
So it's been introduced already. We're gonna be focusing on practical skills in our work as dementia professionals. And we have 3 sections: assessment, communication, and non-pharmacological interventions. For the assessment, we'll be looking at a couple of mini case studies. Then we'll look at some of the tools that are out there to diagnose or at least get an idea if somebody may have dementia. And there's a wide variety available. So I want to introduce one kind of from each different section there is. Then we'll zoom in on communication. I have a lot of do's and don'ts to share. And I have some video examples of me interacting with somebody with quite severe dementia. And just I will tell you the do's and don'ts also of what I got right and what I could have improved. And then we'll focus on non-pharmacological interventions. Last week we spoke quite long about Montessori for dementia. Today I want to switch to spaced retrieval, which is a method to teach people with dementia to learn. And then I'll give a brief overview of other non-pharmacological interventions and basically why they work. If time permits, because I realize I put a lot of slides and a lot of ideas to share with you, I would love to have a discussion with you all and see if together, and you more than me, I believe, we can think about how do we adapt all this information to the local context of Indonesia, but even more so the regions we are in, because it's such a diverse country with very many islands, cultures, backgrounds. So let's see if we make it. I'll just get started and launch into our mini case discussion. So if you were not here last week, don't worry about it too much. I think it will all make sense. Also, there will be questions just before the break and at the end of the session. So please don't be shy, ask anything that has been unclear for you. So last week we talked about the differences between normal aging, mild cognitive impairment, and dementia, where mild cognitive impairment can be a stage between normal aging and dementia, but in around 80–90% of the cases, it's just a standalone period in somebody's life that can even be reversed, or may just be stationary, or in those odd cases, it will develop into dementia. Okay. I'll just read the cases to you, so you don't necessarily have to read it yourself. I'll just talk you through it. So the idea is that you for yourself have a bit of a guess that does this person are they aging normally? Do they maybe have some mild cognitive impairment, or is this someone with dementia? So Harry keeps visiting his general practitioner. He is in good health himself, but he is worried about his wife, Anna. So we're talking about Anna. Anna was a primary school teacher and has always been energetic and full of life. But since she retired 5 years ago, she seems to have slowed down a bit. She still smiles and laughs a lot, but she sleeps longer in the mornings and mainly likes to read books in her comfortable chair or talk with her friends in a coffee cafe. When he asks, she always goes for a walk with him. Sometimes she forgets the day of the week and says it is Tuesday when it's actually Wednesday. If you want to put a guess in the chat, feel free. You don't have to. Again, I will talk you through it, but I'll just leave it on the screen for just a moment. And then this is an example of somebody aging normally. And the biggest cue, I've highlighted it in bold and underscored, is that she retired. And as we discussed last week, what happens when people retire, especially the days of the weeks, come a little bit more blurry, so that she forgets that last sentence, Tuesday, as she says Tuesday instead of Wednesday. That can be due to just retirement, having less structure, having less activities. All the positive indicators that this is normal aging is that she still has a really good mood. She reads, she meets with friends, she goes for a walk when the husband prompts her. So she's active cognitively, socially, and physically as well. So there's nothing in this little description that points to any problems with memory. If there's any questions per case, I'm also happy to take them because it might be a bit hard to memorize them at the end. But Arjo, you will check the chat for us, please. Just see it. Okay, we continue still between normal aging, MCI, or dementia. Margaret has not been to see her general practitioner in a long time. Recently, her daughter visited for a minor health issue herself, and in the same visit, the daughter shared that her mom seemed more forgetful and recently called her Annabelle, which was her mother's name, so the mother of Margaret. Margaret also frequently calls and shares that she believes that people are stealing things from inside her house. When Sarah then comes to check, she once found the key in the door and a pen in the refrigerator. The doctor decides to visit Margaret at home, and with Margaret's approval, he comes by on a Tuesday at 10 a.m. However, Margaret is not at home, and when they call her on her mobile, she says she does not remember any appointment, and it is Wednesday anyway, isn't it? So I sneak the Tuesday-Wednesday confusion in there. Again, however, I think it's pretty obvious that something else is going on here for Margaret. I would label her with suspected dementia. The first indicator is that she kind of seems to avoid the general practitioners. That's always an indication. Then the use of her mother's name for her daughter. So she's not only not remember Sarah's name, but she's also starting to mix up in time. So she might have reversed to a period in time where she's the child and her mom is still around. Usually when people reach this age, their parents are deceased. I think the biggest cue in this one is that suspicion of she misplaces her own things, but instead of realizing or admitting, it's very tender, all of this in the early stages of dementia. Her logical explanation is people are stealing from me. We call this confabulation, where especially people with early stages of dementia kind of create narratives that fit, and especially fit usually means that nothing's wrong with them. So there's a gap because they think they put their key somewhere, yet the key is not there. And then they create this story of somebody took it because I put it there. I think I remember I putting it there. It's a very, very delicate process, this. Obviously, she could be right, but because we know the daughter comes and checks and then found the key sticking in the door, which of course you hope nobody would do, depending on where you live, but it's not the best idea. And also a cleaned pan in the fridge, that's not where it belongs. So there seems to be a mix of what's going on. And then the last indicator, that confusion in time, thinking it's another day and also not remembering the appointment, it both points to memory issues as well as a disorientation in time. So that's why I choose dementia over MCI, because MCI would mean only one of the domains is impaired. And clearly there's more going on. Continuing here. Now let's look at delirium, depression, and dementia. So two other psychiatric syndromes that are very closely related. I'm not gonna give anything away. The first case is Henny, and he is acutely admitted to the emergency department of the hospital. He has been brought in by the police, unfortunately, who had received a phone call from Henny's neighbors. Henny was calling at their door in the middle of the night. He seemed to have some wounds on his feet. The attending policewoman shared that Henny had told her that he had been under attack in his own home by horsemen. Upon admission, some tests were done, as you always do, and his urine, when sampled, was nearly brown of color. I think you all recognize what this is, I would say. It's a delirium, which you can label as acute dementia, and it tends to happen more often in people with dementia, and this man had early stages dementia. The reason I label it as delirium is the acute admission, and also the sad fact that he's brought in by the authorities. That always means there's been an upset, right? And the upset is he's calling at other people's houses, which during the day would be fine, but in the middle of the night can be quite frightening for people as well. And he also has these wounds on his feet. So somewhere during that moment when he thought he's under attack, he hurt himself. Clearly, the whole attack is one big hallucination, which has followed from being severely dehydrated, which is one of the causes of delirium as well. So I think the big takeaways is the horseman, again, like the previous woman, unfortunately, sometimes burglars come to someone's house, but we know that was not really the case. Yeah, that's the delirium. Again, any questions, please put them in the chat and we'll get into it. Another one for delirium, depression, or dementia. So now we look at Mira, who has been asked by her son to visit her physician. When he meets her, she presents with a poker face, which means no visible emotions. And she talks rather slow and quite flat with little intonation. Mira is not entirely sure what the time of day is and also why she has to visit the doctor. When prompted by her son, Mira admits that she feels somewhat lost since she retired from her work. She has no good reason to get up in the morning and usually rises around lunchtime. She eats a small lunch and usually just a sandwich for dinner. Consequently, she has lost significant weight. And I forgot to put, I think it's on the next slide, but she experienced a guilt around having retired from work and she feels she doesn't contribute to society anymore. So for Mira, I would be thinking more about major depression. Again, the first sentence is quite important, that she was asked by someone else to go see the physician. Again, that may point a little bit to care avoidance. And then even just the nonverbal part of how she presents points to depression. So I think one of the misconceptions about depression is that people stop experiencing joy, which is true. However, they also not display many of the other emotions. So angry, sad, everything becomes very flat. So both her voice and her face reflect this kind of numbness, lack of emotions. So poker face means a very tight face. It may look a little bit on the anxious or stressed side. It doesn't look soft in any way. And then also her voice, that lack of intonation of, liveliness is an indication. She's a bit disoriented in time, which could point to dementia, but in the context of the cases, it could point to depression as well. And she feels lost and guilty, which is one of the important indicators for depression. So she struggles with sleep. She's oversleeping, sleeping until midday, compared to the first case of the woman who would now get up around 9 o'clock. 9 o'clock is not a problem at all, but if we see older people rising at 12, it's definitely an indication. And also her lack of appetite, and then under eating and losing weight is one of the indicators of depression. Okay, and the last two cases focus on what type of dementia does this person have. So Fred has always been high functioning and used to be a CEO at an agricultural company. He traveled around the world to learn about the newest and latest in his field. He retired 10 years ago and has traveled for leisure, picked up many hobbies. He enjoys spending time with his family. When he turned 80, 2 years ago, he seemed to slow down and especially lost interest in traveling. He started dreading the long flights and felt he did not adapt as well to new environments. He prefers to stay home. Half a year ago, with a sudden onset, his thinking seemed to slow down even more, and even planning his day seems a challenge. His wife now starts to notice angry outbursts, something he has never been prone to, so he didn't have any of those. So for this person, I would lean towards a vascular dementia. And almost, you see, I didn't highlight a whole lot, and that is the whole description until half a year ago is normal aging. So him slowing down a bit, losing his interest in travel, this is not yet an indication that something is cognitively wrong. Obviously, his high age is an indicator for any type of dementia happening. The reason I lean towards vascular dementia is that memory loss is not at the center of his problems, but that slowing down and trouble with planning, so thinking and planning, become impaired in vascular dementia. And then a change in emotional presentation as well. And we spoke about this last week, but say, for example, if Fred had always a disposition to sometimes being really angry, we don't use that as an indication. But for this Fred, it was a real change in who he used to be. And then it becomes one of the most important indicators that, hey, something may have changed in the brain. And then we have John. He has visited his doctor and expressed a concern that he has Alzheimer's. He is a still working child psychiatrist and recognizes some of the symptoms from his medical studies. When his doctor performs some tests, John does not seem to be forgetful and is well oriented in place and time. Also, he's only 52 years old. But John shares reluctantly that his colleagues have some concerns about his work. He made some questionable diagnoses recently. John explained those away because of his sleep problems. He shares he is one of the best doctors he knows. During the consult, for a moment, John seems to see someone outside the window and even nods his head, but no one is there. When John gets up to leave, his doctor notices that his limbs are somewhat stiff and he takes rather small steps. So John thought himself maybe Alzheimer's. That was to throw you all off, because I think we might be looking at somebody with suspected Lewy body dementia. And I keep using the word suspected because also we talked about this last week. It's very hard to diagnose a person during life. And quite often there's a mix of dementias going on. So for the sake of simplifying, I've presented these cases as, kind of clear cut. But for example, for John, we could also suspect he has Alzheimer's and Lewy body. The reason I put him here as Lewy body is he's young. Alzheimer's disease usually occurs after 65 years of age. Lewy body can occur earlier, but not before the age of 50, or that would be very rare. Another indication that he doesn't have Alzheimer's is that he's not forgetful and he's well oriented in place and time. Then that the symptoms that we see present, and this is much more clinical interpretation and judgment than John sharing this. But first of all, he mentioned sleep problems, which is indicative of Lewy body dementia. He says he's one of the best doctors he knows. This is usually not how we talk about ourselves. That could be an indication of him being a little bit delusional and a bit of grandeur happening. I think it's really borderline. He could also feel quite defensive because he has received criticism. But in the context of everything else that's going on, it could be an indication. And then that little incident where he seems to see somebody, but his doctor doesn't. And that could be hallucinating. And finally, the way he walks, his gait, some stiffness and taking small steps. These are also the changes in ambulation point to Lewy body dementia. And this is what Lewy body has in common with Parkinson's. Okay. These are our case studies. I hope that helped to give more insight about what it looks like. Now I want to introduce 4 different measures that are available for measuring dementia. I'm saying the very general word because it's different per measure what you actually can establish. So here you see the MMSE. This is in the research especially kind of perceived as the golden standard for first-line screening. The positives are it only takes 5 to 10 minutes to administer, and it touches on all the domains that are relevant for dementia. So you see orientation items. So people are asked, what's the year? What's the month? Where are we? What hospital? Then they are given 3 objects. In the English version, it's apple, table, and penny. They are asked to repeat it. And then later on, they are asked to recall those. They do some sums. The recall item is after the sums. And then there's some language. So they have to recognize a couple of objects. They have to repeat a sentence. They get a 3-stage instruction that they need to follow. They need to read a sentence and do what it says. They need to write a sentence that needs to be logical. And then they have to copy this figure at the bottom. When we were working, actually also this was in the Malang region in Bendo, if I'm not mistaken, where Elizabeth, Dr. Schrader does a lot of her work. And we tried to do the Indonesian version of mini mental state. And our rater came back rather upset. She felt it was highly inappropriate. The person she did it with was rather upset as well. So there's a lot of issues, and for time constraints, I can't dive in it too much. But first of all, these kind of questionnaires should not only be translated language-wise, but there should be a cultural adaptation. So not all of the items are relevant to countries everywhere around the world. But the second thing is, for me, broader than like the cultural translation. This test feels a lot like a test. So they directly launch into what's the year, the month, the date. And I think a lot of people have the awareness that they should know how to answer, but then they can't. So there's almost added on stress of feeling that, oh my goodness, this person came and they want me to do well. It adds extra pressure. Another thing is that Salis and all said, well, we can't really detect early stage dementia. So it's not really sensitive to that. It can distinguish between the suspected, I think this person has dementia versus I don't think they have dementia. Until now, the cutoff point is under 24 out of a score of 30. However, Salis et al. Said, well, it needs to be under 26.1, so 26 and lower. So there's a lot of debate still. I would suggest that MMSE is really helpful, just like as a first line screening, just getting a very good idea if the person goes through the items easily, feels familiar. And the only thing to then, if you use it in that way to be really aware of is, are they not feeling very stressed or anxious because they feel they're being subjected to a test, because that can highly impact their performance on the test. Another option is the R-bands. It does the same as the MMSE. However, it takes a little bit more time and it just dives a bit deeper into all of the important domains. So as I said, the MMSE is 5 to 10 minutes. This questionnaire takes 25 to 30 minutes. Because there's more information, it also helps with detecting MCI and early dementia better than the MMSE. It has more than one form. It has 4 different forms, 4 different versions. So it's also really helps that you kind of avoid retesting, people remembering what they may have done on another day. It looks at the domains immediate and delayed memory, spatial awareness, language, and attention again. And at the end, the scoring process is a little bit complicated, but it does correct for age. So not every person is subjected to the same, is expected to have the same score. If you're older, the boundaries become a little bit lower. And this figure, I'm not sure if you can see my mouse, but the figure in the middle bottom, that's the figure people first have to copy. Let me show you what they had to copy for the MMSE here in the top right. And then this is for the R-bands. And not only do they copy it, but they also have to recall it at the end of the assessment. And for me, it's very hard to score. There's a lot of detail and you almost always want to do it with somebody else. But the minute, so quite many people in, say, early onset dementia, not early onset, sorry, early dementia are quite well able to copy it, but then struggle with the recall. So you might have an almost complete figure or complete in the just copying stage, but then at the end of the assessment, they will just draw a rectangle and that's it. Or there might be a circle, but it's in the wrong location. And then you also have people who even already struggle with copying it. So they have this in front of them, but their whole coordination of hand and brain, it just doesn't function as well. So there's a lot of information there. We're zooming out more and more. The clinical dementia rating scale. We talked about it briefly last week, but I'll just revisit it for a moment. It becomes much more of an interview, a conversation, and it first talks to a close informant is the word they use, which just means the partner or an adult child. It can be a professional, but then also with the person themselves. And it's much more of a conversation. So it feels less as a test. However, that being said, the first question asked to both informant and the person themselves is, do you or does your partner have problem with memory or thinking? So I think that's still quite the question to start a conversation with. Thankfully, it is encouraged to first have just a more general chat, just to kind of build that rapport, right? It takes 50 to 60 minutes. So this is kind of the cost, right? That the more we dive into it, the longer it takes. So it also, you have to find a balance between how much time do we have and what are we trying to achieve. One of the really important elements is you speak to the informant, the spouse first, and you ask them about 2 recent events. And one is a week ago, within the last week, and one is 1 month ago. And the idea is you ask a whole lot of questions. So let's say they visited a family member, they stayed for dinner. You're going to ask about the exact times, which can be difficult. But what did you all eat? What did you talk about? Who was there? How did you get there? How did you get home? Did anything out of the ordinary happen? And then later, when you meet with the person themselves, you're going to try and see if they remember the event, first of all. And if they do, what details they'll still remember. So again, you get this wealth of information. The MMSE might just be a rough indication. However, the scoring is very straightforward and you just follow the rules, the regulations, and you have your score. When we get into a clinical dementia rating, your clinical judgment becomes so much more important because you follow all the questions that you have in front of you. However, there's a lot of room to ask follow-up questions, especially when there's discrepancies, or when you just feel you don't have enough information. And then at the end of all of it, you use the scoring sheet that you see here in front of you, and you have to integrate the information from the informant and the person with dementia. And most pronounced for the domain of orientation in time and place, the two are quite discrepant. So you might have an informant who says, oh yeah, they're great, they know where they are. And then you do the items, which is again, by the way, the similar test as what's the year, the day, and the person themselves scores quite badly. And then you as a clinician have to see, okay, are they very stressed about this part? Are they nervous? Quite often when I monitor some of the scoring, these people have been in a doctor's office for most of the day. They might be tired. So, okay, where does my benefit of the doubt go? Which one do I weigh more? And the opposite happens as well, that the informant will say, they're great, they know where they are. The opposite example. So they really, really struggle. The informant is saying they have no idea where they are. They get even lost in their own house. And then you go through the items with the person themselves and they make no mistakes at all. And again, that could have multiple reasons. Maybe the family member doesn't see them as often and just doesn't really know. Thankfully, a lot of people will tell you that. Or maybe the person with dementia has a very good day. This happens as well. They might be very lucid, very chatty, and just know everything. So your clinical judgment kind of really needs to monitor, observe, and come to conclusions. And obviously, we always suggest talking to colleagues when you're really unsure. And one of the rules is if you really can't determine your score, you choose the worst one. So the worst cognitive function for that domain. There's a calculation usually done as an algorithm, which will give you a total score. And there's also a weighted score where memory becomes more important in the end score. And then the last one, this is an observation sheet that we used in one of our studies. Now, as you see, first of all, the form looks rather complicated. So this requires good training of everybody who's doing observations. What we did there is, let's just focus on the top half. So it says target behaviors. We would choose one highly frequent misunderstood behavior. In most cases, this was wandering or pacing around. And for every minute, we would note, does this person display this behavior or not? We had an intervention. However, we would start observing before the intervention. So 30 minutes in kind of a baseline situation, we would look at this person. What are they doing when they're left to their own devices? Then an interventionist would come, do one-on-one activities with the person, again for 30 minutes. The observations continued. The interventionist would leave. The observer still stays on another 30 minutes because we wanted to know, has this one-on-one interaction any after effect? So you have an observer who's there for 90 minutes, an interventionist in the middle for 30 minutes. The same study, the middle part, we also had to note the predominant effect, emotion, in every minute. This was a struggle in that we really had to monitor, okay, how long are they smiling for? And because we chose a minute as the duration, we ended up scoring a lot of neutral because we learned during this study that emotions like pleasure and anger, it's more in outbursts. So we adapted that for next study. Really informative though for us was the engagement part at the bottom. So again, for every minute we looked at, is this person actively engaged with their environment or the interventionist during those 30 minutes? Are they more passively engaged, which means they're listening or looking at something, but they're not actively talking or doing? Are they not engaged, or are they self-engaged? Quite many people, when they have dementia, they start fiddling with themselves. So non and self-engaged would be the more negative engagements that you don't really want for people. So this is the explanation. It's very lengthy, isn't it? And that was the challenge from doing this. However, we got a wealth of information. It is personalized and the most objective of all the measures I shared with you, because you're not relying on anybody telling you what's going on, not the person themselves, not their family members. Family members can be great, same as for professionals, like they can be really good, but especially if for professionals, if they work with more than one person, they might have developed preferences. I like this person, or they have kind of a way of perceiving somebody, and they put all that behavior in the same box of this person is just very unhappy and always complains. And that's our issue with informants, right? It's subjective. It's their impression, and they're humans. They have feelings, so they might get along or be frustrated, any of those, and that will color what they tell you. And that's okay as long as we are aware. But this method just gives you a whole lot more objective information. And also it really helps for the nonverbal participants because it doesn't rely on speech. All right, that completes the first section based on a measurement assessment. I think we open the floor for a couple of questions if you have any, and then we'll have a brief break and come back to talk about communication. Pak Aryo?
Baik, Bapak Ibu, the discussion for the presentation for the first section is already presented by Dr. Eva, and now we can discuss about the first section about the assessment of dementia. Maybe the audience have any question about the first section of the presentation. Please, you can write your question in the chat room, or yeah, there is one, Dr. Eva.
Yeah, I'm reading also. Thank you so much, Doctor. I believe you were present last week as well and had another excellent question. I'm really happy you're asking me this as well. I really like your way of thinking as well. For me, I would always start with it's a message that we need to understand. And if it turns out that the message, the underlying need is pain, we can always reach for this is a symptom that we have medicinal treatment for. We're going to treat them pharmacologically. But my starting point would always be this person has dementia. They're displaying behavior that's different than before. Let's first find out where, instead of jumping to conclusions. It's a bit of a brief answer, but that would be my starting point, always.
Okay, Dr. Andika, cukup? Cukup, Dr. Andika?
I think he's typing.
Yeah, maybe.
I can see him.
Maybe while waiting the response from Dr. Andika, we can move to another question first, Dr. Eva.
Sure.
Is
Yes.
there any question? Yeah. You can also ask your question in Bahasa Indonesia, as Dr. Eva is well in Bahasa Indonesia also.
Yes, please.
Silahkan, Bapak Ibu. Masih ada pertanyaan lain?
Saya Pak Aryo.
Oh iya, monggo.
Ya, Bu Eva, yang slide form terakhir yang dipakai tadi Bu Eva, yang tool, yang untuk observe apa tadi? Tulisannya kecil sekali. Bu Eva, the last tools yang Bu Eva tampilkan tadi.
Wait. This one?
Ya. Bu Eva bisa explain more tentang penggunaan tool ini, Bu Eva? Target behavior seed Montessori study.
Oh yeah. Would you like me to explain the top part, the details of the study? Okay, great.
Yeah.
Hang on, I need to move us because we're covering. There we go. That's better. Yeah, so this is the top part is more just the layout of how we designed the study. This is for administration purposes, but it gives a lot of insight into how our study was designed. So we did a crossover randomized trial, which means every person was exposed to an intervention, which was Montessori for dementia, a certain type of interacting during this time slot. And we had a control condition. This was designed by my supervisor, my boss, Professor Daniel O'Connor, and it was very cleverly done, if I may say so, that he realized that if we start doing activities all of a sudden, so that our participants were living in nursing homes, they were in public nursing homes. Later on in the study, we would visit some private ones. There's a huge difference in what that looks like. If I'm being a little bit blunt, the environments are very bleak. This is people's home, yet it looks like a hospital. And that's just for practical reasons. It's easy to keep it clean. It's easy to do any interventions, but it doesn't look like a home. Also, there's great staff around, but they provide care. They do medical interventions and they help with ADL, the activities of daily living, such as cleaning, eating. So the basic of needs are being met for sure, but there's not any time for these professionals to sit down, have a chat, and have a social interactions. We visited people who had very severe dementia. If we talk in terms of MMSE, it was usually under 10, and quite many people were approaching 0. So they weren't really able to do an MMSE anymore. Sadly, this quite often also means that the family doesn't visit as much. Just basically, this is not a judgment. They just don't know how, because a conversation doesn't work anymore. And they're not equipped, they're not taught, like, is there something else we can do? So it becomes a very sad occasion for everyone. And sadly, people conclude, well, I visit less and less. It's something that happens. So these people are socially deprived. So if we come in and do an activity session, we want to know the added value of the Montessori and not just the value of exposure to social contact. And if you remember Busri from last week, the effect on the target behaviors, they were reduced both in Montessori and control, meaning that the control worked really well as well, which makes perfect sense. People are social creatures. So what we did was 4 sessions in Montessori condition, 4 sessions in control condition, and they were swapped over after that period. So at the top, our raters would know we're in week 1, we are observation number 1 or 2 would be Montessori or control. And then the person has a code. They write the initial of their colleague who would do the intervention. They write their own initials, the date and the time. So basically, all participants had 8 visits from the observer and the interventionist. During 4 visits, we would do Montessori, and the other 4, we would do social interaction. Bu Sri, does that answer your question?
Iya. Jadi ini Bu Eva melakukan untuk research only apa untuk practical? Jadi daily practical Bu Eva juga melakukan measurement atau assessment ini?
During this work, this study, I did both. So I was the supervisor of the team. I would do some of the Montessori sessions myself to learn it as best as possible and also really understand what my other researchers were doing. Because doing Montessori for half an hour, it doesn't sound long, but it requires you to be very present. So it's very intense. Sometimes I would do some of the observations myself. Also, again, to really know what's going on, to understand if the measures was working, and sometimes just because somebody else had to cancel. So I think for this project, I worked with different CAPs and got to know the whole process and spend a lot of time in the nursing home with the people themselves, which was really good for me.
Okay, thank you, Bu Eva.
Sama-sama.
Terima kasih Bu Eva.
Pak Aryo?
Ya,
Yeah. Can I ask one question, please?
ya silakan Dr. Tita.
Yes. Good morning, Dr. Eva.
Good morning.
I think that your presentation was very interesting and thought-provoking. My name is Tita, and I am a general practitioner. So, following what Dr. Sri asking you just now, that one challenge I often face is diagnosing dementia in the clinical setting and differentiating it from cognitive impairment in post-stroke patients. So could you explain how I can make a quick and practical assessment to distinguish between the two in my daily practice? Thank you.
Thank you so much, Dr. Tita. I believe we've met at some point before, so wonderful to see you. I am at least very familiar with your name as well. Look, I wish I could say it can be quick, because I know this is, as a doctor, usually where you need to find the balance, right? Fast is good because you have so many other people to see, things to do, your administration, it just builds and builds from there. The thing I would recommend, if we were in this luxury, we can choose whatever we want. We need to collect a lot of information. We need to meet the person, observe them, if we can talk to them, and then we need to talk to their families, their wider communities, if we can. So we want to collect as much as we can. But I hear what you're saying, there's not so much time. So maybe for the first line, we would refer back to something as an MMSC, but more culturally appropriate. And I think I said it takes 5 to 10 minutes. Maybe we as professionals can say, let's take 15 minutes, where we first introduce what we're doing, why we're doing, and acknowledge that, look, this is going to feel like a test. But please don't be nervous. You can say something silly, almost like there's no right and wrong. The information is confidential. I will not talk to anyone else without your permission. But just to ease them in that test of what's the year, what's the month, what's the date. But for in terms of efficiency for you, I do believe it's a first line measure that will help. The distinction between MCI and dementia is then, for MCI, they would only score poorly on one domain. So for example, they are very disoriented in time and place, but all their sentences, their language, the drawing, it's all fine. We're more thinking about dementia when they start kind of making smaller or bigger mistakes across all domains. That would be a very brief version of how to distinguish between the two. But I don't know if the recording of last week will be available, because we talked quite long about how do we separate these normal aging from MCI, from dementia, because that's one of the hardest parts of the job.
Okay, thank you so much, Dr. Eva. It is helpful. Thank you, Pak Aryo.
Ya, terima kasih, Dr. Rita. Maybe you can check the video for the previous class from Dr. Eva.
Dr. Eva.
Is there still have time, Dr. Eva, for one more question, or we just
Yes,
ya?
please.
Ada pertanyaan lagi, Bapak Ibu?
Hello, Dr. Eva. I would like to ask.
Yes.
Uh,
Silakan, Dr. Karina. Halo. Sepertinya putus-putus, Dr. Karina.
patient with schizophrenia who had long.
Dr. Karina, mohon maaf. Suaranya tadi putus, Dr. Karina. Bisa mungkin
Oh,
diulang ya? Ya, mohon maaf.
Apa sudah terdengar ya, Dokter Pak Aryo? Sudah terdengar.
oke.
Oh, iya.
Ya.
I would like to ask about older patient with schizophrenia who had been long diagnosed with schizophrenia for about 30 or 40 years. How do we differentiate if they have cognitive decline because of their schizophrenia, or is it already related to dementia or MCI? Thank you.
Thank you, Dr. Corina. And another question so relevant to practice, and you're all touching on the difficult, the sore spots of our work, right? I mean, I love your awareness already. And I think we can always make the assumption that if one thing is not functioning right in the brain, which presents in schizophrenia, we can almost count on it that at some point there's going to be more, because the brain is out of balance. And I talked about this last week. I used the metaphor of if a patient presents with a broken leg, we know what it is. It could be severe, it could be minor, it can heal easily or not so easily, but there's protocols and we can follow them. With the brain, not so much. Every person is different. So your awareness that this person has schizophrenia and now they're at an older age and they might develop is beautiful. I think I would suggest what I suggest for healthy older people also, that the minute the person with schizophrenia changes again and has symptoms that you or your colleagues have never seen before, that's where you click and start exploring, hey, is there now added on dementia? The most difficult dementia to detect in people with schizophrenia would be your Lewy body dementia, because that looks the same. It has hallucinations, delusions. So I'm not sure if that's more prevalent, but that would be very hard to distinguish, and probably you can't during life, I would say. However, for your Alzheimer's, it could be an amelioration of more memory problems, more disorientation in time, and maybe even more personality and emotional changes. I keep saying more because I know, as far as I'm familiar with schizophrenia, all these things might be happening as well. But I think when you see changes that are really distinct and they persist over time, so it's not a one time you see them and they're different, the next time they're back to who they were, you might want to explore it. But I would say this is one of the hardest challenges in your work.
Okay, thank you very much, Dr. Eva.
Sama-sama.
Yeah, I think the discussion for the first section is already enough ya, Dr. Eva. Terima kasih, Dr. Eva, for the valuable insight from you and para partisipan yang telah berdiskusi. Now, so we have a 10-minute breaks, Dr. Eva?
Yes, please.
Yeah.
Yes. We all stretch our legs and come back.
Yeah, thank you. We will have 10-minute breaks, Bapak Ibu, and then we back after the 9:15. We will be back. Okay. Thank you very much, Dr. Eva. We will start in 3 minutes later. Eva, or just start? 3 minutes later, okay.
We can start. I have so much to tell still. So if you're okay, let's continue.
Okay, yeah. Please, time is yours.
Oh, yes.
Sorry.
No problem.
It's okay, Eva.
Oh, good. Yeah. No.
Yeah. Okay.
Just adapting. Wait, let me move some things. Yeah. No, that's not something. Okay, so we continue about communication with people with dementia. And I made quite a number of slides with do's and don'ts. However, before I start showing those, I really want to emphasize that probably some of the things you'll see you are already doing. What I'm trying to do is present a complete overview, as complete as I can. So please take no offense if you are thinking to yourself, I do this, I couldn't be happier. So some of it is more relevant for maybe you yourself. It might be new information. However, other parts might be more for you to share with, for example, a family member or someone who's living with dementia. So please take what is helpful and celebrate everything you already know. And that being said, the first one, yes, the first one is probably one where you go, well, this is obvious. However, I gave a workshop a couple of years ago here in Sangla Hospital, and they were role playing, and I was just observing at this point. And one of the residents basically did exactly the two things that are don'ts on my first two slides, which was he approached a person, his colleague, from behind, and he also remained at a standing while the person was sitting. And when you're role playing, this is kind of the shortcoming of role playing. That's fine, because if you put your hand on somebody's shoulder and they're healthy, they might be a bit startled, but they'll turn around and say hi. What happens with people with dementia, if you do this, is they unfortunately usually will slap you because they're so startled and they don't have the understanding that this is a person coming from behind. So first of all, we approach people as much as we can where they can see us coming. So on the left side, you see a person coming up from behind. Especially if hearing is a bit impaired, they will not be expecting you. So we approach them where they can see us. And the second one, the minute we want to start communicating, we meet at eye level. And I think, especially when you have somebody in a hospital bed and there's a group of doctors coming and they're standing around your bed, it is quite something, because it is almost a power dynamic that we want to avoid. And I think it's a practical reason for doctors, psychologists, that, you know, they're going to go to the next patient soon. But the difference of sitting down next to a person who's lying in bed or sitting themselves, it just creates an equality that can be really, really important to establish rapport and feeling understood. So we try to meet the person at eye level. I often end up squatting and kind of, it's not comfortable, but it means I make contact with the person where we both are. If we talk about walking, it's try to stay together as much as you can. Again, if you're in a hurry, it probably pays off to still stay together with the person, because in the left-hand scenario, we're not really sure what will happen if the person is straining, trying to keep up, maybe getting frustrated. As I said, some of these are very obvious, so please bear with me. If we want to do an assessment, have a conversation, it's really, really important that we appraise our environment. I shared last week that whereas we as healthy cognitive adults have filters, and we can very well distinguish between you talking to me and everything that's in the background, in the periphery. So there might be music, there might be sounds of traffic, but we have an ability to really focus on the thing that requires our attention. You have to imagine that for people with dementia, this filter has been removed. So if we look on the image on the left, there's music coming from somewhere else, could be a neighbor. There's a TV on with loud talking, with maybe something of interest or not. And then there's one person trying to talk to the person with dementia. They will probably not understand. So just to create an environment that is quiet will change your dynamic as well. Always check for assistive devices, glasses, hearing aids, anything that can get quite often misplaced. It's worth searching for it for a minute or 5. I know of family members who will have a number of glasses lying around in the same strength, or a spare hearing device. Again, this is the basics of creating a baseline of how can we communicate. And if the person can't properly hear you or see you, the starting point is very different. Let's say they have a hearing impairment, but they still can't hear you very well, or they can't find it. I've seen more than, especially in the Netherlands for some reason, that people start really shouting, and it's not recommended. So I rather suggest that you sit very close to the person and talk close to their ear in your normal voice. The reason is that in the left-hand scenario, even though you're saying nice things or practical things, neutral things, the minute you raise your voice, it will be associated with your being angry or upset. So it creates a vibe that sets up both of you for an argument or at least a misunderstanding. This is very personal, so don't do this with everyone, especially people you don't know that very well or people of the opposite sex, but sometimes a use of gentle touch can be very comforting. And I would recommend just touching somebody's hand or maybe arm, shoulder. That's about it. It just can provide comfort, but it can also help with attention. So I worked with a lady who had, I believe, something else going on next to Alzheimer's. She definitely had some Alzheimer's, but her attention span was very, very short. So we were doing activities together, and I think every minute, if not more frequent, she would be distracted. And she said she hears people talking about herself. So every single time this would happen, I would gently place my hand on her upper arm and say her name. And every time she would turn back and would be so happy to see me. So here, the use of her name and the touch kind of helped her orient back towards me. How to converse, and this is where it gets a little bit out of the ordinary, I believe, that when we as healthy adults talk to each other, we cross-talk, we are rather quick. With a person with dementia, that's going to increase the confusion. So we need to ask a clear question or present a clear story and then just give some time to respond. It's not for everyone. Some people are still very fast, but you'll pick up on that immediately. Rather start to slow and realize, okay, hey, this person is ready to meet me where I am. But if we keep talking, we'll then see a confused person in front of us, and we might interpret that as even having more cognitive impairment, whereas they just need a moment to process and answer your question. We talked about this a little bit last week as well, when we were talking about the stigma around dementia. Unfortunately, this happens a lot, that people will start, and this is not only for people with dementia, also other psychiatric disorders. It happens a lot with children, unfortunately, but not to talk about the person. I want to add when they're in the room, but maybe even when they're not in the room. I think for as long as we can, we should include the person and use different communication techniques for them to be able to engage with the conversation. I'll get to that in a moment. Then just talk with, say, the spouse or an adult child and start making decisions for them. So especially when you're in the room together, just make them part of the conversation. I mean, you could even be as literal as saying to the person with dementia, I want to talk to your daughter for a moment because we have concerns about this, this, and this. Do you have anything to say? They might not, but at least you've then very gently introduced that you're going to talk to their daughter about them and they can consent to this or not. They might say, no, I'm uncomfortable. So the person should stay leading for as long as possible. This goes back to our tests also, but avoid any questions that sound like a test. So here on the left is a professional or a family member who shows a photo or a photo album and says, do you remember? This is the most ironic question to ask people with Alzheimer's or dementia. It's a confrontation, so we try to stay away. For some reason, it's a question that's quite often asked, and I don't know. It's probably how it's on our mind, so we might accidentally say it. So an alternative would be, well, what do I see in this photo? And that may trigger, oh, this is me and my husband. We were newly married, and there's a story there. So it's not important if they remember. We just ask a question to see if they can. The next one is, so we're getting to the nit and grit of this, avoid very broad general questions. So what would you like to do today? For almost every person with dementia is a question where you will draw a blank. They cannot answer these questions anymore. It's the sheer number of opportunities that presents itself that leaves them speechless. However, if you give them two options, would you like to read a book or go for a walk? Even with people with severe dementia, you usually get an answer. I would love to go for a walk. You can do this, and this is more for your family caregivers. You can help people dress in this way as well. Instead of just dressing them, you could present an outfit and ask which one would you like to wear today? Neither one. Okay, two new ones, that one. They can always point and always say this one. If it does become too hard, but I've never seen this, you could even just present one outfit and still say, would you like to wear this today? So there's always an option. And it's our job or the family member's job as well to present with options they can choose. And we need to adapt, we need to observe and see what they can deal with. Keep it positive. So I'm not one for toxic positivity, but sometimes it gets really, really confrontational. And this can be sheer frustration on the other person's part, because maybe these questions get asked over and over again, but that again means we need to explore what's going on. So if a person has moved in with a relative or maybe to an institute, you might very often get the question, when can I go home? And maybe if this is the 20th time you've been asked, you might snap a bit or somebody else and say, well, after this assessment, and can you now please stop asking this? I know it sounds very rude, but any varieties of this that would invite them to not continue asking the same questions. Imagine those are not really helpful. So as an alternative, when can I go home? It's almost a distraction. And we say, I need your help for a bit longer. Would you mind staying, or is it okay? And again, this is one of the things that almost always works, that you engage them, you invite them, you ask permission as well. I've never seen a person say, no, thank you. It's always, yeah, sure, if you need me, I'm here for you. And we're already, and it's going to get progressively worse, getting into maybe this feels a little bit like a slippery slope. Are we still being honest? But one of the questions, and we can maybe talk about this later, is sometimes being kind becomes much more important than being honest. Let's move on, because there's more of that. So when will I have lunch? This happens a lot, that the person will just have eaten and they come to you, when are we eating? And then maybe because we're busy, we're doing something else, we go, you don't remember the beautiful lunch I made for you. We would say, well, but you just had lunch. Guaranteed the person comes again after 5 minutes saying, when are we having lunch? The alternative is, when will I have lunch? I think it will take a little bit. Are you hungry? No, not really. So then we move it a little bit to, hey, I actually don't need to eat. It's just, it can be very, almost a reflex, this question. We can even dive deeper into this and say, let's make a visual prompt, something on the wall where it's written what the lunchtime is and a clock next to it. And we can then use space retrieval, which we will talk about later, to actually learn a procedure that when the person thinks about lunch, they will go to this place and they see the time and the clock's next to it. And, you know, they asked it at 10 o'clock and it says at 11. So that's, but that's a step further. So we're here more talking about conversations. The grounding in reality, and this is where the slope gets even more slippery. I'm usually a person who advocates for a lot of honesty, but we have to ask with people with dementia and maybe other vulnerable groups as well, is this necessary? And while I'm saying it, I have a great awareness that I come from a culture where we're pretty straightforward and very blunt, which doesn't help. Whereas I feel Indonesian culture has a much more a softness and a respectfulness to this. So some of this will probably become much more natural. So here the person with dementia says, I'm so glad it's the weekend, but they're disoriented in time. So the other person says, hey, but it is Monday. Again, is it necessary? Not really. Does it matter? Not really. However, if you feel you always need to be honest, it's very hard to then change to another response. So, but I'm so glad it's the weekend, right? Did you have a busy work week? So we almost counter with something that can then open the conversation and can give us an insight into the other person's reality. I think that's the essence of this. Their reality is just different than ours. So if they think it's the weekend, it must mean they felt they work. So let's see what they have to tell us about this work week. And then the very, very most challenging one is the grief-specific grounding in reality. So a very sad thing that can happen is that the person's partner, spouse has passed away, can be 2 years, can be 10 years ago, but they have forgotten due to their dementia. So they will ask, when is my husband coming home? And if you feel that reality, grounding in reality is really important, you might in a more gentle way than here on the slide say, but your husband has died. And what happens, because this is news to the person, they will break down or grieve every single time you tell them. So if we want to keep it lighthearted and avoid this hugely stressful news, we might just still say, I think he's still at work, but let me check. So it feels like a little performance, but it helps the situation and the person and you yourself very much. I think this is a really important message for especially family members, that, hey, there is an opportunity. If it does feel very uncomfortable, again, we can work towards an adaptation of the environment. We can make a memory book about the spouse that is in a very prominent place in the house. It could be electronic as well, obviously, but for the older generations, something physical works. And it will have photos and stories from the person's life. And we could train them again that if they are thinking about their husband, they can find this book in this particular place. And when the book is there consistently for a long time, they will start remembering that the person is deceased, and they can celebrate their lives by looking at this book. And as a kind of end stage, when really nothing works, which could just be for today and might be better tomorrow, we might just choose to do something together and completely stir away from any verbal interactions. This feels very uncomfortable at first, but then can become very enjoyable as well. So let me now, and I have to stop sharing. It's going to be a little bit back and forth between the videos I have lined up. So unfortunately, there's no audio, but I will introduce every video one by one. You will meet Geraldine, who is 82, I believe, at the time this video was made. And she was living in a nursing home, diagnosed with severe dementia, very active. She was always on her feet. You'll see she's rather skinny. And for the purpose of us filming, obviously we had permission and everything to do the filming and to share this with everyone. For the filming, one of the staff members had seated her at the table because I needed to come and meet her. But this is not her normal default. So she would normally, oh, I clicked it away. She would normally be up on her feet and walking around. So let's just look first at what she looks like when she's seated at the table without any input or anyone doing something. It's a very brief clip. So she seems in a way disengaged or maybe engaged with something that is not available to us. She's not looking at the camera, which would be something we would probably do, wouldn't we? She moves a bit. I'll just play it once more. Right? She moves a bit and just also observe her facial expression for a moment. And then I ask you to see if the facial or how the facial expression changes. I have to go back and forth every time to share a new one, so bear with me. I'm now showing the video where I come and introduce myself. I'll just show it first, and then when I replay it, I'll talk a little bit. This is one of the mistakes I made. You can't hear the sound, but the chair really screeches, which is awful. So this is one of the people, she was an immigrant to Australia and had lost her fluency in English. She's talking in a language that I don't speak. I could have remained silent. That's not the most comfortable to me, so I keep speaking in English with her. Let's look at it once more, where I explain some of the, especially the Montessori principles and tapping into her habitual memory. So first of all, this takes a while. The screeching chair. And then this is rather uncomfortable for me, but I'm going down and finding where her eyes are. And as you can see, we immediately connect. And she's not looking at me, but she's looking at the flowers, I believe. Also, I just bring one thing. So here again, I presented where she's looking. And I feel she's speaking and I don't understand. I feel I could have stayed a little bit longer with her. I take my time organizing, which is helpful to me. And this is implicit memory. So I put a flower in her vision field, and she's not thinking, you can see that hand just comes up and takes the flower. And I think, if I remember correctly, she says something like, "What's the time?" It meant something entirely different. She was saying something about the flower. What we were a little bit worried about and why the video stops is that sometimes people, unfortunately, will eat something like a flower. She didn't, but we wanted to make sure that it didn't go into the mouth. Then we're at 3 minutes. And again, share. Let me point out my mistake first. And there are so many of them, which is just normal. But this cup I'm using with her is way too small, so I'm really not helping her. And if I would do it again, I would change the cup. But she is engaged. She's trying. Yeah, and I feel if we would have had a bigger vase, she would have been able to put the flowers. The next clip, we're now 6 minutes in. And again, not to criticize myself, but just, you know, there's so many things that we can do better. And this was just for purposes of filming. I feel there's too many clutter on the table. So if I would do this in practice, I would have removed the flowers, taken my time to put those back in my bag, and just focus on folding. I hope you can see this well. And please have a look at Geraldine's face compared to the first shot. So I'm inviting her to join me. Again, she's not doing what I'm doing, but one of the essences of working with people with severe dementia is what's the purpose of what we're doing? And with Geraldine, the purpose was for her to sit down, not walk around basically, and be engaged. And as you can see, she is holding one of the serviettes, the towels, and she's very much, I'll just play it once more. She's really there in the minute, the first eye contact, I think that's on video at least. And if you'd like to comment in the chat maybe about the changes in how she presents, that would be wonderful. Very last video. This is 10 minutes in, only 10 minutes. And she fell asleep. I was very familiar with her, so very comfortable to just touch her hair for a bit and being quite pleased for her because she wouldn't rest. She would be on the go. It goes to show there's a lot of sides to this, that she must have been exhausted and only 10 minutes of doing activities just made her want to snooze. So it's beautiful and it's sad at the same time that this was the outcome. Let me just close all the videos. I would like, if it's okay with Bapa Aryo also, if anybody has questions, sometimes these video kind of trigger a lot of questions. So if anybody would like to comment or something that stood out to you or any questions you have, please do.
Ya, Bapak Ibu, kalau ada pertanyaan, monggo langsung disampaikan tentang video yang telah disampaikan oleh Dr. Eva.
I'll continue, but please just put the questions in the chat already, or anything you observe, and I'll talk for another 20 minutes max, and we can revisit.
Yeah.
Okay, let's continue. So that was the communication part. I now would like to talk a little bit again about the non-pharmacological interventions. So last week I talked a little bit about pharmacological interventions and how unfortunately there's not a working medication for everyone at every stage of dementia. So we need to look for alternatives. And like I said, we have around 20 minutes. I really want to focus on spaced retrieval, which, like Montessori for dementia, was developed by Dr. Cameron Kem. And I focus in on spaced retrieval because I feel it's kind of a very different one than all the other ones that I'm familiar with. And that is because it focuses on learning procedures. And I think if we have any ideas about dementia, one of the first among them would be people cannot learn anymore. They're forgetful, so how on earth can they learn new procedures? Well, the good news is they can. And what inspired Dr. Kemp was he worked a lot in nursing homes, institutions. And what he observed was that people who newly move into this space, there's kind of a whole culture, structure, hierarchy. Within a week time, so this is a deeply unsettling situation, right? They are moved out of their family home. So often they've lived there for decades, and they move into a space where they don't know anyone. A lot of their things cannot move to them. But within a week, despite this unsettling move, they would already know what their seat at the dinner table was. So how would they learn this? How do they know this if they cannot learn? Now, what spaced retrieval does, and I'll get back to the example also of finding your place at the dinner table, but spaced retrieval works with procedural memory. Again, if you couldn't attend last week, please watch the video as well, because we talk about it quite more. So for now, I'll just very briefly summarize. But procedural memory is highly intact in people with dementia, whereas the explicit memory, remembering people's names, objects' names, recent events, sequences, that is what's very impaired and what we can't really access. But through procedural memory, we can train a person, I don't have a better word for it, but to store things in long-term memory still. And the minute something is in your long-term memory, it's there. It can be accessed again. But obviously, that's the hard part. How do we get it when this whole part of the memory, probably the part where we're almost, all of us are most acquainted with, we need to forget about the explicit memory and start working with implicit memory. It involves both priming, and you may be familiar with Pavlov, psychology, where he taught dogs that when they pressed a lever, a certain bell would ring and food would be presented. And within no time, the dogs started salivating at the moment they heard the bell already. This is priming. They expected a certain response based on the stimulus, their input elicited every single time elicited food. So they anticipated this, and this is a learned combination. And it could be positive, like in this case, the sound of a bell, it's almost neutral, but negative feedback, punishment also, of course, really teaches people and any kind of organisms, what you want them to do or not. And poor dogs, once they had learned the association, the experimenters then decided to take away the food at the end and to see what happens. And it took them a long, long time to unlearn this combination. So they kept pressing the lever, and they heard the bell and they start salivating, no food, again and again and again. It took them a very long time to unlearn the association. So if we think back to that idea that, hey, these people find the right seat at the table, their seat, you can imagine that if they, on the first day, they take the wrong seat, they're sitting in somebody's seat that really, really has been there for years. Somebody will probably tell them, or you'll be met with some grumpy faces. This is feedback. And opposite, if you take the seat that wasn't taken before, people will maybe smile and nod at you. So it's very subtle. But if this happens a number of times, every single person knows what is the right thing to do, how to connect socially, which again is really important to us as humans. So implicit memory is intact very far into the dementia. We have observed that even people with an MMSE approaching 0 can still learn and remember. The two most pronounced people I remember was one Michael, who relearned, he couldn't count, but he relearned to count in a session of 30 minutes only. And on another occasion, he had listened to his favorite song during an activity session. And when I was very lucky to witness this myself, I was the observer on this day. The activity session had finished, the person had left, And Michael was walking around, but in a calm, relaxed way, not any pacing. And he was very, very loudly singing this song. It was Tom Jones' Delilah. I learned that the lyrics are pretty morbid, but he loved it. And he was singing it for quite a long time. So all of this is just, something was unlocked in his brain. It was not conscious. And he had a certain behavior that followed naturally from the stimulus. The response is, if I hear the song, I sing the song. Even if I don't hear the song, I now can access the song again. And there's Eddie that I talked a little bit about last week. He used to be an automobile and motor mechanic. And I did activity sessions with him. I wanted to have a very easy in-step, so I had printed a lot of photos of motorbikes. And I wanted to ask him, like, can we sort these into likes or dislikes or maybe brand? And I think on the third or fourth occasion, he had a really good day.
Lansi program penanganan.
Sorry. Instead of sorting, he launched into advising me. And it was a wonderful session because there were some older pictures and he would say, well, don't buy this. This is really old. This won't last very long. So everything he did made sense, and he was completely back into his role as a motor mechanic, selling motorbikes. And the best thing about this, that I revisited him 5 days ago. This is a long time period. And he remembered me. And I don't mean he said, hello, Dr. Eva, how are you today? No, he knew that I had brought him something good. I represented something good. I remember this was a very active person, always on his feet. He very willingly sat down with me. He took my hand, he held my hand, he smiled at me. The sad part of it was that I had to switch. This was at that point that we moved into control activities. So I would just converse with him or read the newspaper. And he didn't find that half as interesting as what we had done. So I did kind of, the connection got a bit lost. I'm saying this mildly ironic. It was still really, really beautiful to have all these effects. So it's intact. And then our procedural memory works with habits, including muscle memory as well. All of this is nonverbal. You don't need to speak to access implicit memory and priming. And it's also unconscious, and it works with procedures. So it's basically an if-then. If you or I, as the outsider, do this, then the person does this. It sounds very simple, doesn't it? If this, then this. That's how it works. And so when we tap into this type of memory, we can teach people with severe brain damage new procedures. Now, space retrieval mostly works with priming. So what we did was trying to teach people who were fall prone, so at risk of falling, to always use their walker when they got up to walk. So this is one of the dangers of dementia, right? They have an assistive device that could really help them, but they forget about it. So what space retrieval asks you to do is, first of all, choose a very clear goal, a very unambiguous goal. You're only doing one thing in one moment at a time. If it works well, you can do another goal next week. So in our case, it was to avoid falls, or more specific, to use their walkers. And then you need the very clear procedure. So we said when they get up from their chair, which could be replaced by bed, etc., but we start with chairs, they should reach for their walkers. What is implied if we want to do this? People need to know, first of all, where their walkers is. So you might almost do a sort of pre-training to help them park walkers maybe in designated places. So it sounds simple, but there may always be a pre-training step as well. So when we had our goal and our procedure, we had to formulate our question and answers. So basically, space retrieval training with the person with dementia consists of the trainer asking a question and teaching the person the correct answer. So in our case, the question was, what do you do when you get up from your chair? And their answer had to be something, it doesn't need to be verbatim, but when I get up from my chair, I reach for my walker. And almost as a check or a double learning, we would also instruct them to give us a nonverbal answer. So not only say the words, but also show us what that looks like. So they needed to reach for their walker. They didn't need to get up every time, because especially in the beginning, that would be very high frequent and can be very exhausting. But at least show us where the walker is and reach for it. The first step in the actual training, so this all was still our preparation, was to introduce the question and the answer at the same time. So we would say, the whole introduction, I'm gonna teach you or a new procedure. We would like you to always walk with your walker. There could be a little bit of discussion why that was relevant. And we would introduce that I'm gonna ask you this question and this is the answer I'm expecting you to give. So first of all, the trainer introduces them, then they ask the question again and they invite the person to reply with no delay at all. If the person does not yet know the answer, the trainer just keeps repeating the combination and inviting them every time to see if the answer is available, which usually it is at this point. Then from the moment they start answering correctly, we start using the spaced retrieval part where we start spacing out the questions. So we've given them the question answer combination. We've checked that they understood it in that moment. And now we can start building a time interval which becomes longer and longer before we ask the question again. So baseline was example given, question asked, answer given. Now we wait 10 seconds. We ask the question again. They give the correct answer. We wait 20 seconds and we build from there. The time intervals you choose can be different depending on who you're working with and what you're doing. But you build it up all the way until 30 minutes. So at that point, there's 30 minutes where both of you can do something else. And you just set a timer and you come back 30 minutes later and you ask your questions again. As long as the answer given is correct, the intervals keep lengthening. However, if at some point the person does not remember the answer, gives an incorrect answer, or says, I don't know, we go back to the previously correctly answered time frame. So let's say in the time frames I chose, after the 5-minute interval, they do not know the answer anymore. The trainer will share the answer right away and then goes back to that 2-minute time interval before they ask the question again. They continue from here. These sessions can be long and intense, and even when I'm talking, I almost feel, and I would think the same, how are we gonna do this? This is not something we as clinicians can do, and you're absolutely right. But these are tools that either you can set up a team of specialists that are outside our professions, they can have a different background, that really focus on keeping people, this is what it does. It makes them more independent. And in the end, more and prolonged independence means less work for us. If people just deteriorate and deteriorate, the burden for family members and the intensity of using healthcare resources becomes bigger and bigger. So keeping people autonomous and independent would be such a good thing. But we need to do this whole investment. So that could be something, and I don't think we have time today for the discussion about the adaptation to your daily practice, but that could be something to really think about. So these sessions, they go for as long as needed. Clearly, guiding is how the person is doing. If they get exhausted, there is no need to continue, and we revisit them the next day. Even if the information is retained on a first training day, which means it's retained for the 30-minute interval, we still continue the training for one other day. And we restart at the last interval. So if they remembered it at 30 minutes, we would reintroduce on the next day the question and answer and wait for 30 minutes And if they then answer correctly again, it means this information has been stored in their long-term memory. Other things, practical things that can be very helpful is how to find the toilet. Almost always we need some assistive prompts in the environment as well. So to find a toilet, especially if a person moved house, can be very distressful and also result in accidents, which are inconvenient for everyone. But if we're willing to put signs referring the person to where the toilet is, and I know this is very out of the box and we don't live in houses with signs to where the toilet is, but if it prevents the other person from maybe urinating in the plants, this would be most helpful. Not only for the family member who might need to clean it, but also in terms of dignity for the person themselves. There's a whole lot more to say about what the sign should look like. They need to have a big font letters, but also an image preferably, and it would be great to have the person's input. And another example that can apply to so many things, and I shared it when we were talking about grief, about how do we tell a person that their husband has passed away 10 years ago? But it's the use of a logbook where we refer them, and then the space retrieval comes in to, the question would be, what do I do when I wonder about my husband? The answer they learn is, I go to the book that's on this table. So the book always consistently needs to be in that space. And then they'll see a picture of their spouse on the front of the book. They may have made it together with a family member. And maybe on the front, it already says the year of birth and the year of death. So, okay. And then open it, and there's photos and stories and a lot of good stuff as well. So it could be for something as serious as grief, processing the loss of a spouse, but also questions like, why am I here? When is lunch? Who comes to visit today? So for every single question, they can't memorize this, but they can learn that the information is in this book. And all they need to learn is, when I have a question like this, I need to open the book. And that's where spaced retrieval. So the bigger questions get narrowed down to one simple procedure. And you'll be astonished that almost everything we can translate back into a simple procedure. And maybe you need one or two more procedures. Okay. If you feel this is really relevant, maybe you have a research component to your studies and you want to explore this. First of all, I highly recommend it because it's wonderful to visit, to witness and do. But these are the questions you should ask yourself. So what kind of information, which procedure do I want them to store in their long-term memory? It needs to be very unambiguous and straightforward. Which simple procedure do they need to learn to reach that goal? So that's where we're making it even more specific. Then even more specific, what questions do I ask them? And trial the question, make sure that it's not have an element that confuses anyone. And then which answer should be given. And I also highly recommend to have that non-verbal answer in place as well. Can I talk for 2 more minutes? Very briefly. So these, I'll just leave these is an overview of other non-pharmacological interventions. Unfortunately, I can't share the details. What I loved, I know eBoost 3 is working with the bottom one as well, pet and plants therapy, animal and green therapy. There are all these beautiful things going on, including dementia-friendly communities, which are whole villages that are being designed, and people in the community are being trained to recognize people with dementia and change their communication style to something that would fit them. The one I really recommend to check out is humor therapy by Professor Brodati in Sydney and his research group. I think Professor Brodati is still active. At first, when I heard about it, I was really afraid it would be strange or disrespectful, but it's done by beautiful people who really, really connect with people with dementia, and the joy they bring is astonishing. It's really beautiful to witness. Let me just, I'll do the takeaway messages and then I stop and the floor is open for questions. And this goes back to today, but also last week. So the things I hope you will take away is, first of all, we leave the losses for what they are. We don't disregard them. We don't ignore them, but it doesn't become our sole or main focus. We start looking for what is still possible. And that changes the mind shift to hope. It's a different narrative. We may want to learn more about implicit memory, priming, procedural memory, and see how that can assist us in our daily work. And through implicit memory, that access point, we really tap into the lifelong interest, activities, habits, and even muscle memories. We change our role. Instead of caring for, we start focusing on promoting independence and autonomy. And we take up an active role and become an observer and a detective. Because every single person we see will be different. We just learned that learning is still possible. And the third point on this slide is become one of my own passion, especially for family members, but sometimes also for professionals. That one of the things to do is to never forget about ourselves. And I think especially for family members caring for a spouse or adult children caring for their parents, even more so, I would say, in a country like Indonesia, where familial ties are so strong and there's such a commitment to each other. Please check in with the family carers that do all the work. Often it comes down to one person. Often it comes down to a daughter or a daughter-in-law who, in addition to caring for an older parent or spouse, is also caring for children and for grandchildren, and they actually also maybe doing a bit of work on the side. But to revisit that, okay, they need to be okay to keep looking, to keep looking after everyone. So it could be unfamiliar, but it could be something to explore. And this can be explicit, but it can also be more implicit, just like organizing respite care for a day, where somebody else spends the time with the person with dementia. Me personally, I've really benefited from mindfulness. I know you have very similar ideas, procedures in your culture, in your religion as well, which is just beautiful. So I think a lot of that just comes natural. And the very last point is the how is much more important than the what. You can do anything. It's about how we approach it. So my summary would be, we need to be inclusive with a kind attention and an awareness. I'll stop talking there. There's more. We stop here. Thank you so much. And the floor is open for any questions. Pak Aryo?
Yeah, thank you very much, Dr. Eva. Thank you very much for the valuable insight from you, very interesting. And actually, we already have 4 questions in the chat, Dr. Eva. Mm-hmm. And I limited the question for only 4 because the time is very limited. Is it okay, Dr. Eva?
Yes.
Yes. The first question is come from Yusia. She asked about how to involve participant from a patient with dementia with cognitive impairment. How you can involve them.
Yes.
Thank you.
Wow. There's a more than one answer, I think, and it really depends on how they're functioning. The first thing to explore, Dr. Yusia, in my opinion, would be how are they functioning, and not that appraisal needs a little bit of time. So we need to. One of the assumptions quite often is that people can't read. If they haven't been able to read their whole life, obviously this hasn't changed. But if they were able to read before, we need to do a reading test. And we let them read, but in different fonts, in different contrasts. So we enable again that if we give them an A4 with very small font, very small spacing, they probably can't read that, but there might be something else to read that they are able to read. So we really need to know who they are and what they are capable of. In terms of interviewing them, if you have people in the very early stages, you might just give it a go as you would with healthy adults. Otherwise, it's a matter of adapting your interview questions and especially your interview style. So being prepared to rephrase questions, allowing for more time to answer. I wouldn't recommend having anybody to support them in the room because they can hijack the meeting and they probably have a lot on their mind and they may start answering things that are relevant to them. Monitoring how your questions are perceived, how quickly the person might tire if they don't have a lot of social interactions or they don't converse a lot because they're not asked to. This can be very tiring. An alternative, which I presented earlier, would be not to be so verbally reliant. So we steer away from talking, but we start observations. And there's so much information in looking at a person and seeing what they're doing. So the version I presented looked at certain behaviors, it looked at their emotional state, and it looked at how engaged they are. I felt, especially when we move towards severe, moderate, severe dementia, there's a source of information there that's mainly untapped. But this is one of the paradigms shifts in dementia care. We cannot rely on language and conversations as much as we do when we're amongst healthy, cognitively healthy adults.
Thank you, Dr. Eva. How about the answer, Dr. Yusia? Hello? I think we can move to other question, Dr. Eva. The second question is come from Dr. Tita again.
Yes.
And yeah, maybe I will read it for you, Dr. Eva. I once had an elderly patient come to my practice with significant hearing and visual impairment, and I also suspected that she might have dementia. She actually came in because of flu-like symptom, but I found it very difficult to take a proper history because of her sensory limitation. As general practitioner, what would you recommend I do in a situation like this? Should I still prescribe medication even if there is no caregiver or family member available to supervise the patient? Or would it be better to refer the patient directly to an internist or another specialist? I found this particular case quite confusing because I wasn't sure what the most appropriate next step was. Could you share some practical insight on how I should approach a patient like this in primary care? Yeah.
Wonderful. Yeah, I think this beautiful question helps me to summarize what I'm presenting today in that care for dementia, people with dementia, I think it slows you down as well. So in this case, you first need to address the sensory impairment. So this person needs to be equipped with fitting glasses, with the correct prescription, and fitting hearing aids. We can't move from there into other complaints without knowing which parts of her impairments are due because she cannot hear and see very well. So again, and this is where the time issue comes in, but the first step would be to refer this person to get hearing and visual impairment evaluated and get appropriate assistive devices, and then meet back once the person is wearing these. Maybe needs a short period to get comfortable with that. You mentioned the flu-like symptoms. I mean, that could be something that can't wait. So as a psychologist, I think I'm on slippery ice to give this advice, but to me, it makes sense to maybe prescribe something for this. But I think your clinical judgment would be much better than mine. But to look into the dementia, we can only do that when we know in how far the hearing and visual is influencing. We had a case in the study I did with Professor Hajani and Dr. Schroeder-Butterfield, where I felt the person was misdiagnosed as having dementia, whereas she had had profound visual impairment. She received an operation that left her blind. And so first of all, this is a huge change from being a visual person to non-visual, but she was furious. And she had repeated shouting behaviors, which were labeled as part of dementia. Whereas when I read the case, I went, well, this woman is really angry and upset that, you know, she was doing okay. And she chose to do an elective surgery and now she can't see anything. So yeah, we need to know the influence of these, and that could be one of the steps in your evaluation. We need to know that all the assistive devices, as far as they're available, they are in place. Then we can move on to the next step.
Thank you very much, Dr. Eva. Bu Tita, is that answered your question? Yeah.
Okay, thank you so much, Dr. Eva. Your answer was very helpful and gave me valuable insight that I can apply when assessing and managing my patient in daily practice. Thank you again. Thank you, Pak
Thank you
Aryo.
so much.
Yeah. Terima kasih, Bu Tita. We move to the next. Is it okay, Dr. Eva? It's already 13 past 10.
Yeah,
Okay,
maybe one last question.
One last question, okay. Mohon maaf untuk Dr. Izah dan Dr. Tika ya, karena waktunya terbatas sekali. The last question is from Dr. Andika. There are two questions about the communication, and the second is about the non-pharmacological intervention. The first question is, in dementia care, communication is not always about transferring information, but also about understanding the meaning behind the patient's behavior. When a patient can no longer clearly express their needs verbally, how can clinicians ensure that we are truly listening to the patient rather than simply interpreting their behavior based on our own assumption? Maybe the first question first, yeah.
Yes. Yes.
Yeah.
Thank you, Pak Aryo and Dr. Andika as well. Yeah, thanks also for your awareness again of all the things we encounter. I mean, I think every change, every paradigm shift starts with us becoming aware of the complexity of this. So you being aware that you make assumption, which is just, you know, this is how we make sense of the world around us, and we need this tool because otherwise we can't function. You mentioned when a person is not so verbal, I would always revert back to observations, maybe meeting the patient in their natural situation, which could be a natural environment, which can be online as well. We don't always have to visit. And again, back to family history, talking to more than one family informant as well, and integrating that information, understanding that this person brings their own history and maybe frustrations that they might not share explicitly, but that will color their story of how this person is doing. And from there, it's such a long process, isn't it? That, you know, even being aware of your own assumption and putting a question mark on in your brain or on the paper in front of you that, okay, this is my idea and I want to keep the idea, but I want to be open that maybe it's only my assumption and not more than that. The communication style needs to be different. I think we touched on that multiple times, but that would help as well to take much more, allow for time to respond, to maybe change how we ask our questions. So instead of saying, you did something today, can you tell me what? You can describe, look, I heard you did this and this and this. Is that correct? Yes. May I ask why? And this could have been a behavior that triggered other people and was interpreted But instead of taking their version of the story, you check with the person, is this what happened? And okay, yes, that's great. If they say no, it's kind of end of conversation. But quite often people will be honest. And then you can ask, well, may I ask why? And it requires exactly my intonation right there. If you say, well, why would you do that? They will not answer anymore. But if you say, may I ask why? Yes, of course. And they will astonish you with how much more they can access and express when targeted in that different way.
Okay, Dr. Andika. We move to the second question of Dr. Andika, ya, Dr. Eva. The second, when evaluating non-pharmacological intervention in dementia, improvement in behavioral symptoms do not necessarily translate into an improvement in the patient's quality of life. In your opinion, which outcome should be prioritized when these outcomes do not align? And how can researchers ensure that the selected outcome truly reflect the patient perspective rather than primarily the perspective of the caregiver or clinician? Yeah.
Great, thank you. I think this is a real personal preference of mine, but I kind of let go of improving people's quality of life. And this is highly controversial, but I don't know what it means. I don't think it means the same for each and every one of us. So how can we measure that? So generic quality of life measures have items on your finances, your mental health, your physical health, your daily activities. They're usually very broad generic questions. And they're usually not sensitive to the small interventions we're thinking about doing. So you can measure it and you do a remeasurement and it's still about the same. So as a researcher, I don't, and this is like I'm saying, a lot of people do include it. So this is just me. I do not include it. I want to go directly to the source. So when I do an activity intervention, that's why we observed the response in the person. That at the same time eliminates your own perspective, the family members' stories, because you're just looking at the person without asking questions and you're seeing what happens. And if we think back to the videos, if you see this woman who she had kind of a poker face, didn't she? And there was no emotion, or it was just bordering on anxious and anxiety. Then to see her transition into, she had a relaxed face, she smiled a bit, she made eye contact. This is, for me, it's gold. I leave, she changes back, but she's still, in this case, because she fell asleep, she had 10 minutes that were different than her whole day. Is it enough? I don't know. Days are very long, but it's something. And if we would have the resources to have this person linked with somebody else throughout the day, it could make a huge change. So I want to look very directly at, this is what I'm doing and this is what I expect. And I kind of want to reduce all the noise, all the opinions around it. And the straightforward way to do it is observations.
Okay, thank you, Dr. Eva. Dr. Andika, bagaimana? Okay, thank you very much. Mohon maaf, Bapak Ibu, waktunya memang sudah melebihi dari yang ditentukan. Mungkin we can stop the session, Dr. Eva. Terima kasih sangat atas pengalaman yang luar biasa. I was still wondering how challenging to do diagnose a person. We can have very much challenge, and I cannot imagine what we have to do with the dementia patient. Sekali lagi, terima kasih. Thank you very much, Dr. Eva, for sharing your valuable experience, allocating your time for us today. And maybe we can see in the other session. Thank you very much, Dr. Eva. And also for everyone for joining the participation. Thank you very much. And that bring us to the end of the session. And we look forward to see you in the next session with Dr. Tita. Dr. Tita, can we start directly or you have to do a break?
It's all up to you, Pak Aryo. I'm ready.
Oke, thank you very much. Mungkin kita langsung aja ya, Dr. Tita. Okay. As it is a 3-in-1 program, Dr. Tita, the first speaker is from international lecturer, and the second is from Bu Tita. Dr. Tita is from practitioner in Indonesia, so you can use your bahasa Indonesia or English. It is a 3-in-1. Yeah. Okay. Before we start, saya kembali ke setelan awal, Bu Tita. Saya akan memberikan introduction untuk Dr. Tita yang akan memberikan topik crafting the narrative, structuring qualitative article for international journals. Sebelum kita mulai, saya mohon izin untuk menyampaikan CV narasumber Dr. Tita. Narasumber kita adalah Dr. Tita Haryanti, MKes. Bu Tita menyelesaikan pendidikan dokter di Universitas Brawijaya dan melanjutkan pendidikan magister kesehatan di Universitas Airlangga dan pendidikan doktoral di Universitas Gadjah Mada. Saat ini Dr. Tita adalah dosen di Departemen Ilmu Kesehatan Masyarakat Fakultas Kedokteran Universitas Brawijaya dan beliau sebagai praktisi juga dalam geriatric care ya, Bu Tita, di Teja Husada. Beliau aktif dalam penelitian dan pengabdian kepada masyarakat di bidang kesehatan masyarakat serta menghasilkan berbagai publikasi ilmiah. Dr. Tita juga merupakan salah satu pionir dalam pengembangan penelitian kualitatif di Fakultas Kedokteran Universitas Brawijaya. Dengan pengalaman beliau, saya yakin pada sesi hari ini kita akan mendapatkan banyak insight mengenai bagaimana menyusun hasil penelitian kualitatif yang menarik untuk artikel publikasi ilmiah. Terima kasih. Tanpa panjang lebar, mari kita sambut Dr. Tita Haryanti untuk menyampaikan materinya. Monggo, dipersilakan Dr. Tita.
Nggih, matur nuwun Pak Aryo, setelan awal pakai bahasa Jawa ya. Nggih. Saya izin share dulu. Sudah tampak Pak Aryo?
Bapak, Bu Tita, jelas. Terima kasih.
Maaf. Baik, bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi menjelang siang Bapak Ibu dan rekan-rekan sekalian. Sekarang saya duduk di kursi panas ini ya, istilahnya Pak Aryo, karena harus bercerita tentang materi yang sejatinya sulit buat saya yang ditugaskan oleh Dr. Sri sebagai koordinator program 3-in-1 ini, yaitu crafting the narrative, a qualitative article structure for international journal. Itu sulit banget, mengingat bahwa sejujurnya saat ini saya masih sedang berjuang juga untuk menyasar jurnal bereputasi dengan Q yang tinggi untuk jurnal-jurnal, artikel-artikel kualitatif yang pernah saya lakukan bersama mahasiswa. Nah, tapi hari ini saya tidak ingin mengajak Bapak Ibu untuk belajar bagaimana menulis artikel kualitatif dengan cara yang biasa. Sekali lagi saat ini karena saya sedang berjuang untuk mendapatkan hati dari para reviewer artikel kualitatif saya gitu ya. Semalam pun saya harus ini final revision gitu ya, tapi ya itu memang harus dilalui seorang penulis bahwa kalau pengen tulisannya bagus ya sudah harus berani di review gitu ya. Namun saya juga tidak ingin mengulang kembali bahwa sebuah artikel ini terdiri dari introduction, methods, result, discussion, dan conclusion. Enggak, saya enggak ingin mengulang kembali dan saya tidak ingin mengajari Bapak Ibu. Karena saya sangat yakin gitu ya, sebagian besar dari kita itu sudah sangat familiar dengan struktur tersebut. Baik itu jurnal internasional maupun jurnal nasional yang terakreditasi, semuanya ya gitu-gitu aja gitu ya. Namun pertanyaan saya hari ini sebetulnya justru lebih sederhana, tetapi mungkin sedikit mengganggu gitu ya. Karena menurut kita biasanya itu, menurut penelitian itu menurut kita bagus gitu, datanya kaya, apalagi kualitatif, itu datanya luar biasa kaya Bapak Ibu. Bahkan kalau kita menggali data dengan baik dan benar, itu tidak sekedar bahwa A berhubungan dengan B gitu ya, A ada pengaruh dengan B, tidak, tapi bahkan sampai ke implikasi yang bahkan kita nggak tanya gitu, karena sejatinya pada waktu kita berdiskusi atau melakukan in-depth interview pada partisipan itu, yang kita tanyakan itu cuma satu, jawabnya beratus-ratus gitu, ya, dan bahkan sampai implikasi penelitian. Nah, pertanyaan yang lebih mengganggu adalah mengapa penelitian yang menurut kita bagus, datanya kan kaya, informannya menarik, analisisnya sudah dilakukan dengan serius sesuai dengan pendekatan penelitian kualitatif, tapi ketika dikirim ke jurnal internasional, lo kok ditolak gitu ya. Sehingga menjadikan kita itu berulang kali di submit ke sini ditolak, disubmit ke sini ditolak gitu ya. Yang ini major revision dan lain sebagainya. Sebetulnya kita bisa bertanya dalam hati kita, apa sebenarnya yang kurang? Lalu apa datanya? Apa metodologinya? Apa bahasa Inggrisnya? Atau mungkin sebenarnya ya bukan itu masalahnya gitu. Maka saya ingin mengajak Bapak Ibu peserta untuk melihat artikel kualitatif dari perspektif yang sedikit berbeda. Karena artikel kualitatif ini bukan sekedar tempat untuk melaporkan apa yang kita temukan, tapi artikel kualitatif adalah tempat kita membangun sebuah argumentasi ilmiah dari data yang kita miliki. Saya ulangi bahwa artikel kualitatif bukan sekedar tempat untuk melaporkan apa yang sudah kita temukan, tapi adalah tempat kita membangun sebuah argumentasi ilmiah dari data kaya yang kita miliki. Dan argumentasi itu harus punya cerita gitu. Jadi selama kurang lebih 60 menit ke depan, saya ingin kita berpindah posisi. Dari researcher menjadi author, dari peneliti menjadi penulis, itu berbeda banget. Dan orang yang mengumpulkan data ini menjadi orang yang membangun makna dari data. Bukan sekedar data, tapi orang-orang yang mengumpulkan data ini menjadi orang yang membangun makna dari kata. Dan dari sekedar menulis laporan penelitian menjadi crafting the narrative, merajut cerita. Nah, mari kita mulai dari pertanyaan yang mungkin paling menyakitkan bagi seorang peneliti, yaitu kenapa penelitian kita atau artikel kita ini rejected. Dan itu pasti pernah dialami oleh seluruh penulis, seluruh peneliti yang akan mensubmitkan seluruh tulisannya itu ke jurnal-jurnal yang berkualitas, gitu ya. Nah, saya ingin bercerita saja. Tadi saya sudah senang Pak Aryo ketika Pak Aryo agak melebihkan jamnya Bu Eva tadi, ya alhamdulillah gitu ya, karena saya juga merasa bahwa saya bukan orang yang sangat pantas untuk bercerita ini. Saya hanya ingin sharing tentang pengalaman saya ketika mensubmit penelitian kualitatif ini ke jurnal internasional bereputasi. Sebuah perjuangan yang tiada habisnya Bapak Ibu, karena kalau sekarang saya ingin mengajak Bapak Ibu membayangkan sejenak bahwa kita semua bukan author, tapi kita semua adalah reviewer jurnal internasional. Di meja kita ini ada setumpuk manuskrip. Kita ambil sebuah manuskrip, dan ketika kita baca, peneliti itu mengatakan kami sudah melakukan 20 wawancara gitu kan. Kami menemukan 5 tema gitu kan. Biasanya begitu ya, ya karena itu yang saya lakukan. Kami mempunyai banyak kutipan-kutipan menarik. Nah, ini tidak bisa dihindari bahwa kutipan yang kita usung di sana pastilah kutipan yang sangat fenomenal, pastilah kutipan yang sangat unik, pastilah kutipan yang menurut kita itu akan membuat reviewer itu tertarik pada artikel ini. Dan yang luar biasa adalah kami peneliti ini sudah melakukan tematik analisis, apapun jenisnya ya, mau interpretif, mau tematik analisis, mau spiraling analisis gitu ya. Nah, tapi apakah kemudian itu yang kita tanyakan, kami sudah melakukan 20 wawancara, menemukan 5 tema, mempunyai banyak kutipan menarik, sudah melakukan tematik analisis itu, apakah itu otomatis membuat artikel kita itu menjadi bagus? Jawabannya ya belum tentu. Tak mesti katanya itu ya, tak mesti, nggak selalu gitu ya. Nah, ada 3 hal besar yang membuat seringkali artikel kita itu rejected. Yang pertama adalah, poin yang paling penting itu adalah too deskriptif, sangat deskriptif. Seringkali peneliti kualitatif itu karena wawancaranya itu seneng kita ya sebagai peneliti itu seneng dapat hasil wawancara banyak, hasil wawancaranya menyentuh hati, bahkan ketika wawancara itu aja partisipannya nangis, penelitinya ikut nangis gitu ya. Yo gak nangis terseduh-seduh tapi ikut berebes gitu. Kan sering terjadi seperti itu. Tapi ini jebakan yang sangat sering terjadi dalam penelitian kualitatif, sangat sering terjadi. Kita peneliti merasa mempunyai data yang sangat kaya, terus kita merasa memiliki tugas untuk menunjukkan kekayaan data itu kepada para pembaca. Nah, sehingga yang sering saya alami juga adalah result kita itu jadinya seperti partisipan 1 mengatakan ini, partisipan 2 mengatakan itu, partisipan 3 mengatakan hal lain. Lalu kita berpindah ke tema berikutnya tergantung dari berapa tema yang kita miliki. Itu dari POV-nya penulis. Sekarang kita berpindah ke POV-nya si reviewer. Terus reviewernya itu baca manuskrip kita atau artikel kita. Itu yang kalau Arema itu akan bilang kemudian terus ate diapakno gitu ya. Atau bahasa Inggrisnya so what gitu. Apa makna dari semua itu? Gitu. Maka tugas kita sebagai penulis adalah bukan sekedar menceritakan kekayaan data kita, tapi kita memaknai dari apa yang sudah disampaikan partisipan. Apa makna dari semua itu? Contohnya, kalau kita meneliti pengalaman pasien kanker, oh ya, terima kasih di sini saya lihat ada beberapa alumni MMRS yang ikut juga meramaikan seminar pada hari ini, pagi hari ini sampai siang, juga ke Dr. Eva tadi juga ikut gitu ya. Nah, mohon maaf ini contoh-contohnya tidak bisa saya ambil karena ini adalah untuk klinisi ya, dan saya yakin tapi teman-teman bisa mengambil intinya. Nah, berikan contoh sederhana, misalnya gini, kita meneliti pengalaman pasien kanker. Kalau kita mengatakan informan 1, pasien merasa takut. Informan 2, pasien merasa cemas. Informan 3, pasien membutuhkan dukungan keluarga. Itu adalah deskripsi. Sangat deskriptif. Tapi ketika kemudian dijelaskan apa makna ketakutan itu dalam konteks hubungan pasien dengan sistem pelayanan kesehatan, apa makna ketakutan itu ketika dihubungkan dengan apa yang harus dilakukan dokter. Seperti yang tadi saya tanyakan kepada Dr. Eva, bahwa saya pernah di tempat praktek saya seorang dokter umum, dan ketika ada seorang lansia yang datang sendirian, saya selalu bertanya, kali sinten Bu, sama siapa Bu, gitu ya. Nah, terus ternyata dia bilang sendirian. Oke, sendirian gitu kan. Terus itu pun butuh perjuangan yang luar biasa Bapak Ibu ketika saya datang sendirian. Bu, kali sinten Bu, nopo? Kali sinten Bu, napane gitu kan. Itu kan butuh perjuangan luar biasa. Nah, ketika kemudian saya hanya melihat bahwa oke, partisipan pertama merasa bingung atau merasa kesulitan berdiskusi dengan dokternya, ya kan semua pasien lansia itu yang dengan keterbatasan pendengaran maupun penglihatan memiliki keterbatasan komunikasi dengan dokternya terus gitu kan. Maka maknanya adalah interpretasinya, lah terus kalau dokternya memberikan obat flu Bu, ini 3 kali sehari. Bu, ini antibiotik diminum sampai 5 hari sampai habis. Dan dia tidak mudah mendengar, tidak bisa melihat obat kita dengan jelas, dia sendirian ke ruang dokter, terus maknanya apa? Maka dari kita hanya mengupas data tadi, kita mulai bergerak ke interpretasi. Jadi jangan terlalu deskriptif, itu yang seringkali rejected oleh jurnal-jurnal internasional bereputasi. Gitu. Masalah kedua adalah zero conceptual contribution, atau itu artinya adalah kita mungkin memiliki data yang sangat bagus, tapi ketika setelah reviewer membaca semuanya, dia kemudian nanya pada dirinya sendiri, iya wis apik wis gitu ya, apik wis iki wis, datanya sangat kaya, but what did I learn that I did not know before? Artinya adalah bahwa ini apa yang bisa saya pelajari dari data-data yang ya kan aku seru bahwa pasien kanker itu ketakutan, pasien kanker itu cemas gitu. Kan aku sudah tahu. Terus jadi failing to answer the critical question. Jadi gagal untuk iya terus kayak gitu. Jadi kayak terus gitu kan. Jadi kalau tadi what did I learn that I did not know before, itu jawabannya adalah iya, ternyata pasien juga mengalami hal yang selama ini sudah kita tahu atau sudah kita duga. Maka masalahnya ya di sini ini penelitian kita mungkin benar, tapi belum tentu novel atau belum tentu baru. Ya, jadi kalau kita menyampaikan data-datanya, being true is not enough. Your manuscript has to be meaningful. Jadi tidak cukup untuk kemudian hanya menyampaikan data yang kaya, tapi juga harus meaningful. Itu adalah masalah kedua. Jadi conceptual contribution-nya zero, nggak ada gitu. Setelah aku dapat data, setelah reviewer ini melihat, oh ya datanya bagus, so what? Nggak bisa dijawab, ya udah rejected. Atau biasanya major revision, seperti yang saya alami, major revision, itu sampai 8 bulan, luar biasa. Gitu. Nah, kemudian poin ketiga adalah, jadi ini ceritanya moderator, saya tidak mengajari, tapi saya curhat, saya curhat dan menyampaikan sharing pengalaman yang pernah saya lakukan. Jadi kalau Bapak Ibu peserta mungkin pernah mengalami hal yang berbeda, tentunya karena background kita berbeda dan kemudian mungkin jurnal yang kita sasar berbeda gitu ya. Setiap orang memiliki pengalaman masing-masing karena setiap jurnal memiliki selingkungnya masing-masing gitu. Dan yang ketiga adalah no storyline. Artinya bahwa kita sering tidak menyadari bahwa kita mungkin mempunyai introduction yang bagus, metodenya bagus, resultnya bagus, discussionnya bagus, tapi ketika semua digabungkan gak ada hubungannya. Itu kalau di parian itu Joko sembung numpak getek, gak nyambung rek gitu ya. Jadi ketika introduction berbicara A, riset kemudian resultnya kemudian menemukan B, discussionnya tiba-tiba membahas C, sudah tidak ada benang merahnya. Biasanya PPDS, mahasiswa S2, mahasiswa S3 itu sering itu digitukan sama pembimbing atau pengujinya, nggak ada benang merahnya, mulai introduction sampai conclusion itu nggak ada benang merahnya, yaitu no storyline. Jadi secara parsial itu semuanya mungkin benar, semuanya mungkin bagus, tetapi secara manuskrip dia tidak mempunyai red thread istilahnya, benang merah. Jadi pesan yang ingin saya titipkan adalah publikasi internasional ini bukan hanya tentang apakah data kita benar, tapi tentang bagaimana data tersebut ditenun menjadi sebuah argumentasi yang koheren, konseptual, dan bermakna. Oleh karena itu, kita perlu membedakan sesuatu yang sering kita anggap sama, gitu ya. Research and story. Nah, ini bedanya, research and story. Kalau kita lihat, di sini ada 3, ada research, ada story, ada jurnal gitu. Kita harus mengubah research kita yang berisi tentang fakta dan data menjadi sebuah story yang memiliki storyline dengan naratif dan argumentasi supaya layak untuk masuk ke dalam jurnal yang memiliki academic structure di masing-masing jurnal itu. Karena prestigious journal do not publish data. They publish stories built from data, gitu ya. Bisa dibedakan ya. Jadi jurnal-jurnal yang bereputasi tadi itu tidak mempublish data gitu, tidak mempublikasikan data yang dimiliki Bapak Ibu. Mereka itu mempublikasi cerita yang dibangun dari data gitu. Kalau kita lihat di sebelah kiri ini research-nya, di sana ada data, ada interview transkrip ya verbatim gitu, ada field notes, ada observation sudah ruwet dengan coding, ada kategoris gitu ya, yang kalau setiap konsultasi dicorei pakai bolpen merah itu sama pembimbingnya gitu ya. Kayaknya saya tuh. Semuanya itu bahan mentah Bapak Ibu. Itu bagus tapi semuanya itu raw data, bahan mentah. Kalau kayak di penelitian kuantitatif itu ya koyok R-nya sekian, P-nya sekian, kemudian orang puas atau tidak gitu dengan layanan dokter, orang sembuh atau tidak, itu raw data. Lalu di bagian tengah kita mempunyai story. Ini adalah proses intelektual ketika kita mulai bertanya, sebetulnya apa ya yang sedang terjadi di balik data ini? Nah, itu sudah mulai kita membuat story. Sebetulnya apa ya hubungan antara satu temuan dengan temuan yang lain? Biasanya kalau di tesis itu, kalau di kualitatif ada yang namanya interaksi antar tema, itu ada di story-nya itu. Jadi tidak kemudian data. Ini yang sering dikhawatirkan oleh para peneliti kuantitatif. Loh, berarti penelitian kualitatif itu deskriptif ya? Enak aja. Ya enggak toh ya. Tapi kalau Bapak Ibu tidak bisa mempublikasikan data itu sebagai sebuah sintesis, maka asumsi dari para peneliti kuantitatif itu benar adanya. Loh berarti ngene iki yo mek deskriptif toh? Enggak dong. Jadi bahkan kualitatif itu ada yang deskriptif, ada yang analitik, ada yang sintesis gitu ya. Menjadi analitik kalau disintesis dengan baik dan benar gitu. Nah, ketika di bagian tengah kita mempunyai story, ini adalah proses ketika kita mulai bertanya, apa hubungan antara satu temuan dengan temuan yang lain? Bagaimana kontradiksinya? Apakah ada kejutan dari penelitian ini? Atau ada ketidaksesuaian dengan asumsi kita sebelumnya gitu ya. Nah, sehingga setelah masuk ke jurnal paper, itu jangan lupa bahwa kesalahan yang sering kita lakukan adalah kita mengira bahwa artikel yang kita susun di jurnal-jurnal ini adalah transkrip penelitian yang dirapikan. No, big no, no kalau katanya anak sekarang no gitu ya. Padahal tidak, karena research procedures data, analysis procedure meaning, and writing produce the argument. Jadi research itu produces data, penelitian itu menghasilkan data, analisis menghasilkan makna, menulis menghasilkan argumentasi atau sintesa. Saya ulang, kalau di research dan data itu terkumpullah data, fakta, coding, apapun lah ya, categorizing gitu, kategorisasi. Kemudian ketika kita mulai menambahkan story, naratif, argumen, kontribusi teori di situ, maka kita baru boleh memasukkan ke dalam artikel. Karena penelitian menghasilkan data, analisis menghasilkan makna, dan menulis menghasilkan sintesa, menghasilkan argumen, menghasilkan argumentasi. Sehingga ketika Bapak Ibu sudah mulai menulis di jurnal, itu writing lah yang mengubah makna tersebut menjadi sebuah argumentasi ilmiah. Bayangkan kalau kita punya 30 wawancara. 30 wawancara itu bukan artikel. Bahkan 15 tema pun belum tentu artikel. Artikel itu baru mulai terbentuk ketika kita tahu apa cerita utama yang ingin kita sampaikan dari seluruh data tersebut kepada pembaca. Jadi kalau ini di kelas gitu, saya selalu ingin bilang bahwa Bapak Ibu coba deh berpikir sebentar tentang satu penelitian yang sedang dikerjakan sekarang. Dr. Yusia sedang mengerjakan penelitian kualitatif, jadi tentunya sudah mulai menganalisis dan kemudian melakukan interaksi antar tema. Dan itu gegeran sama saya sebagai pembimbing metodologinya. Berhari-hari Dr. Yusia di sini dan hanya untuk menemukan tema dan interaksi antar temanya gitu. Nah, kalau saya meminta Bapak Ibu menjelaskan penelitian yang sedang dilakukan kepada saya dalam satu kalimat, apa yang akan Bapak Ibu katakan? Ya, itu saja sudah membuat kita, yo sakjane saya punya data banyak ini, simpulannya apa ya? Kalau itu masih sulit dilakukan, ya nggak apa-apa. Justru itu yang harus kita lakukan ketika kita akan menulis artikel untuk disubmit di jurnal internasional ataupun nasional. Gitu. Nah, sebelum kita menulis satu halaman pun sebetulnya saya ingin kita melakukan satu latihan sebetulnya ya. Karena ini judulnya workshop sebetulnya, tapi ya karena kita sedang di online agak sulit, tapi saya menyebutnya sebagai the 3 judgment question. 3 judgment question sebelum kita menulis satu halaman pun ketika nulis di artikel. Yang pertama adalah the study is actually about gitu ya, sebetulnya main fokusnya fenomenanya itu adalah penulisan saya atau penelitian saya ini discuss about what gitu, about what. Studi saya ini sebenarnya tentang apa, bukan tentang semua hal yang ditemukan, bukan tentang semua variabel yang kita miliki, bukan tentang cerita informan, tetapi satu fenomena inti. Contohnya, kalau kita meneliti tentang pengalaman nurses, pengalaman perawat yang berhadapan dengan moral distress di ICU. Ya kemudian ketika partisipan ngomong kalau di kualitatif itu peneliti itu bertanya kepada partisipan satu hal, ceritanya bisa berhal-hal gitu ya. Nah, tapi jangan terjebak pada itu, kita tentukan dulu penelitian ini adalah untuk the experience of nurses, pengalaman perawat ketika menghadapi moral distress di ICU. Ya jangan kemudian cerita kita ini melebar jadi workload lah, leadership lah, burnout, salary, teamwork, patient safety, organizational culture. Ya semuanya mungkin sudah dijawab, semuanya mungkin ada, tapi pertanyaannya adalah apa cerita utamanya? Sama ketika Bapak Ibu sedang menulis artikel, itu dilihat lagi apa cerita utamanya, mulai dari abstrak, introduction, method, results, discussion sampai conclusion, itu cerita utamanya apa dan dicari benang merahnya. Itu yang menjadikan seorang penulis itu menjadi penulis yang bagus atau tidak, karena benang merahnya terjaga dari awal hingga akhir. Pertanyaan kedua, yaitu kita harus mencari knowledge gap atau contribution of the study. Nah, jadi kalau kita menuliskan penelitian ini, apalagi kalau ke jurnal internasional, biasanya reviewer itu kemudian meminta untuk bertanya untuk tentang apa sih kontribusimu sebagai penulis itu dalam penelitian ini, atau kontribusimu dalam ilmu yang sudah ada gitu. Kontribusi ini beda dengan objektif ya, beda dengan tujuan penelitian. Tapi kontribusi ini adalah hal yang perlu dipahami dan diberikan kepada ilmu maupun kepada penelitian itu sendiri dari peneliti atau dari penulis gitu. Jadi kita harus tahu knowledge gap-nya, harus tahu novelty-nya atau keterbaruannya, harus tahu kontribusinya sebelum kita mulai menulis. Jadi kalau saya karena beberapa kali diminta untuk major revision, saya kemudian membaca ulang artikel saya. Oh yo, introduction-nya ini ngomong iki, kok terus jadi tujuannya ini, kok terus jadi metodenya ini, nggak nyambung. Ya maka kita harus merearrange atau membuat ulang yang gatok gitu mulai depan sampai belakang gitu. Jadi mungkin bahkan kalau saya sendiri tuh nulis gitu ya, nulis tangan, oh ya tujuannya iki wis bener apa durung gitu, terus metodenya ini pas apa tidak gitu ya. Itu disampaikan sampai dengan conclusion. Itu akan menjadikan lebih mudah bagi reviewer untuk menilai apakah artikel Bapak Ibu ini menjadi layak atau tidak layak untuk di submit di sebuah jurnal yang bereputasi. Lalu pertanyaan ketiga adalah broad impact for theory and practice gitu ya. So what? Ini yang paling penting. Karena kalau artikelnya tidak pernah dipublikasikan, itu karena saya juga mengajar tentang manajemen pemasaran, itu seringkali kalau saya ngomong tentang positioning itu adalah ketika kita menganggap seseorang kalau kita hilang dari otaknya masyarakat, ya sama di sini seperti seolah-olah kalau kita memejamkan mata sejenak dan kemudian berpikir kalau artikel saya tidak pernah dipublikasikan, apakah ada yang hilang dari dunia ilmu pengetahuan? Nah, itu pertanyaan ini sebenarnya memang terdengar kejam ya, tapi justru inilah pertanyaan yang sering ada di kepalanya reviewer. Oh, cuman gini aja gitu ya. Oh, cuman gini aja. Kalau Bu Tita ini tidak menuliskan ini, kayaknya nggak apa-apa ya, aman-aman aja ya dunia ini gitu, dunia ilmu pengetahuan ini nggak apa-apa ya gitu. Itu yang ada di sering ada di kepalanya reviewer gitu ya. Sehingga kalau Bapak Ibu saat ini sedang menulis, baik itu menulis artikel, penelitian maupun sedang menulis tesis, maka mini exercise-nya adalah Bapak Ibu harus secara sadar mentalnya untuk melengkapi kalimat tersebut. Penelitian saya discuss about lalala. Its real contribution is lalala. And so what? Kalau 3 kalimat ini belum bisa diisi, jangan buru-buru mempercantik bahasa Inggris dalam artikel kita. Karena yang mungkin perlu diperbaiki bukan bahasa Inggrisnya, tapi yang perlu diperbaiki adalah ceritanya atau narasinya. Jadi, tapi kalau ini sudah jelas, kalau ceritanya sudah jelas, pertanyaan berikutnya adalah bagaimana cerita tersebut mengalir dari awal hingga akhir. Ini adalah salah dua contoh penulisan bersama mahasiswa PPDS dan S3, yaitu tentang CTEV. Jadi pada waktu itu Dr. Panji mengajak saya melakukan penelitian kualitatif tentang kenapa seseorang itu yang sudah diketahui CTEV sejak bayi gitu ya, tapi tidak segera melakukan diintervensi atau dioperasi oleh dokter orto. Kenapa gitu? Apa alasan orang tuanya gitu? Ini diungkap dan kemudian hasilnya bagus sampai ke jurnal Q4. Saya sih tadinya juga agak ragu ya, bagaimana mungkin seorang PPDS orto gitu yang melakukan penelitian kualitatif, itu saya juga agak gitu ya, ternyata hasilnya bagus dan tidak ada memang benar-benar kata pepatah itu, bukan pepatah ya, benar-benar yang bahwa tidak ada orang yang tidak bisa melakukan sesuatu kecuali dia tidak mau. Jadi yang bayangan saya PPDS orto itu akan sulit melakukan penelitian kualitatif pun bisa melakukannya. Yang kedua adalah dari salah satu yang sudah hampir publish ya, dari mahasiswa S3 Bu Indah ini juga melakukan penelitian kualitatif tentang sleep disorder, sleep quality pada older adult di Bangka Belitung gitu. Nah itu juga ternyata bisa banyak yang di Bangka Belitung itu ternyata tidak sama dengan orang-orang yang lain atau dengan provinsi yang lain, dan itu diungkap di jurnal Q2 gitu ya. Itu jadi kalau ada kekhawatiran bahwa nanti kalau kualitatif itu nggak bisa di jurnal yang bagus lah, ini sampai Q1 aja ya bisa gitu ya. Ada jurnal-jurnal kualitatif yang sampai Q1 gitu. Nah, ini mungkin salah satu slide yang paling penting dalam presentasi saya hari ini. Saya ingin Bapak Ibu melihat manuskrip itu bukan sebagai kumpulan bagian, tapi sebagai sebuah perjalanan intelektual pembaca. Nah, biasanya kita mulai dari problem. Apa masalah besar yang sedang terjadi dan mengapa pembaca itu harus peduli? Jadi, ketika menuliskan sebuah artikel, maka kualitatif naratif arc-nya itu seperti ini. Jadi harus ada problemnya, harus ada knowledge gap-nya, harus ada research question, main finding, interpretation, conceptual contribution, dan yang terakhir adalah take home message-nya. gitu ya. Jadi kalau kita mulai dari problem itu adalah apa sebetulnya masalah besar yang sedang terjadi dan kenapa pembaca harus tahu gitu, kenapa pembaca harus peduli pada problem itu. Yang kedua, ketika kita bergerak ke gap, itu adalah kita harus memunculkan pertanyaan apa yang belum kita ketahui, bukan sekedar belum ada loh penelitian di Indonesia gitu. Itu belum tentu knowledge gap ya, karena orang Indonesia aja yang nggak banyak meneliti gitu ya. Jadi belum ada loh ini penelitian di Indonesia, itu bukan sebuah gap. Gap itu harus menunjukkan apa yang belum dipahami secara ilmiah. Nah, yang berikutnya adalah research question. Pertanyaan penelitian harus muncul sebagai konsekuensi logis dari gap. Jadi, RQ atau research question should not come from nowhere. Kalau kita mengatakan bahwa previous study itu sudah menunjukkan A, B, D, dan C dan D, kita tetap belum melakukan, kita tetap belum memahami D atau E gitu ya. Maka RQ kita harus masuk ke E. Jadi kalau research questionnya itu dari previous studies-nya itu sudah menunjukkan A, B, dan C, bagaimanapun kita belum mengerti D, maka kita harus masuknya ke D. Research questionnya harus masuk ke D gitu ya. Nah kemudian finding ya, ini agak teoritis yang saya sampaikan ini, tapi si reviewer ini selalu menanyakan hal yang sama di setiap kali kita submit. Apa research questionnya? Apa main findingnya? Bagaimana knowledge gapnya? Itu sama berulang. Jadi apalagi kalau ini kualitatif ya, itu lebih nemen lagi gitu, lebih nemen lagi untuk membuat jurnal kita atau artikel kita itu accepted. Kemudian kita masuk ke finding lah, ini baru harta karun penelitian kita, apa yang kita temukan. Tapi jangan berhenti di finding seperti yang saya sampaikan tadi, lanjut ke interpretasi. Kita harus bertanya, apa yang dimaksud dari finding tadi? Kita memiliki 5 tema, terus gitu kan. Terus interpretasinya apa gitu. Kemudian sampailah ke conceptual contribution. Itu kita harus menunjukkan kepada reviewer bahwa penelitian ini memang bermakna untuk field, untuk lapangan gitu. Nah, di sini conceptual contribution-nya itu muncul. Yang terakhir adalah take home message, dan ini kalau akhirnya pembacanya mengingat satu kalimat dari artikel kita, berarti artikel kita bagus. Itu. Jadi, artikel yang bagus sebenarnya seperti perjalanan. Pembaca berangkat dengan satu pertanyaan, kita membawa dia melewati gap, kita menunjukkan evidence, kita memberi interpretation, dan akhirnya kita membawa dia sampai pada satu pemahaman baru. Jadi, every section should answer a question created by the previous section. Kalau ini terjadi, manuskrip kita terasa mengalir, reviewer bahagia, kita bahagia karena artikelnya submitted dan accepted. Ya. Nah, sekarang kita masuk ke anatomi manuskrip, dan saya ingin mengubah cara kita memandang imrat gitu ya. Imrat-imratan itu gitu. Imrat itu mulai dari introduction, method, results, discussion, and conclusion. Biasanya kita menganggap introduction ya introduction, method ya method, dan selanjutnya sampai dengan conclusion ya conclusion. Tapi artikel yang kuat tidak bekerja seperti itu. Every section has a very specific structural function, but they all must be logically linked by a single main argument, atau benang merahnya itu tadi, thread-nya itu tadi. Gitu. Jadi kalau introduction menjawab why should I care? Kenapa kok aku kudu ero? Kenapa aku reviewer ini kudu peduli ambek sama artikelmu? Kenapa? Problemnya apa? Gapnya apa? Kenapa penelitian ini penting dilakukan? Maka metode harus menjawab how did you answer the question? Dan dalam penelitian kualitatif itu bukan sekedar saya peneliti, saya penulis sudah melakukan wawancara, tapi diubah POV-nya menjadi mengapa wawancara adalah pendekatan yang tepat untuk menjawab pertanyaan ini. Mengapa wawancara tidak cukup dan harus ditambahkan observasi untuk penelitian ini. Mengapa harus ditambahkan FGD dalam penelitian ini? Kenapa harus dilakukan studi dokumen pada penelitian ini? Jadi tidak sekedar metode ya metode, tidak, tapi karena kita menjawab why should I care, dan ketika sudah dijawab, maka how did you answer the question itu harus dituliskan di method. Dan resultnya itu menjawab what did you find, tapi bukan data dump, bukan hanya sekedar data gitu ya. Nah yang terakhir di discussion itu menjawab what does it mean, karena di discussion itu sejatinya adalah jantung intelektual dari sebuah artikel. Dan di conclusion menjawab, so what should the reader remember? Jadi kalau sudah mulai bagus dari awal hingga akhir, conclusionnya itu yang seperti memorable experience. What should the reader remember? Apa sih yang harus diingat oleh pembaca ini tentang artikelmu? Jadi bayangkan 5 bagian ini seperti 5 orang dalam satu tim. Mereka punya tugas yang berbeda, tapi bekerja untuk tujuan yang sama. Kalau introduction mengatakan satu hal, resultnya mengatakan hal yang lain, discussion pergi ke arah yang berbeda lagi, maka tim ini tidak mempunyai satu visi, tidak mempunyai satu strategi. Jadi kalimat kunci untuk kita membuat sebuah manuskrip yang bagus adalah IMRAT ini, Introduction, Methodology, Result, and Discussion, sampai dengan conclusion, itu adalah memiliki different functions, one argument. Fungsi boleh beda, tapi argumennya tetap harus satu. Nah, mari kita masuk ke lebih detail bahwa introduction itu seringkali menjadi tempat peneliti memasukkan semua teori yang mereka tahu. Saya juga melakukannya. Karena merasa ini penting loh gitu. Saya sudah baca 40 jurnal loh gitu. Tapi kan reviewer bukan nanya how much literature did you read? Berapa banyak literatur yang enggak ditanya begitu. Pertanyaannya what problem are you establishing? Jadi masalah ini apa guys gitu ya. Jadi introduction harus mempersempit fokus pembaca dari dunia yang sangat luas menuju problem, menuju gap, menuju tujuan penelitian. Harus. Jadi yang dibaca banyak 40-50 artikel gitu ya. Tapi kemudian penulis harus kemudian menuju ke problemnya. Oh gapnya begini dan tujuan penelitiannya ini. Methodology itu di method itu jangan hanya menulis we conducted a qualitative study atau data were collected through interviews atau thematic analysis was conducted. Enggak. Bukan hanya menulis itu. Reviewer itu ingin tahu kenapa menggunakan metode ini. Why this method? Mengapa pendekatan ini, metode ini paling sesuai? Contoh, kalau kita pertanyaan penelitiannya adalah bagaimana pasien memiliki pengalaman hidup yang dengan chronic pain gitu ya. How do patient experience living with chronic pain? Maka kita harus menunjukkan kenapa pendekatan yang kita pilih itu memang memungkinkan kita memahami experience tersebut. Jadi kalau disimpulkan itu bahasa Inggrisnya itu adalah method should demonstrate methodological fit, not merely methodological activity. Artinya metode itu menunjukkan apakah metode yang kita pilih ini memang pas dengan tujuan penelitian. Bukan berapa banyak aktivitas metodologis yang kita lakukan, tapi apakah metode kita itu fit dengan research question-nya. Itu yang harus kita tonjolkan dalam penelitian kualitatif. Nah, sekarang kita sampai pada bagian yang paling sering menjadi masalah dalam artikel kualitatif. Termasuk saya sendiri melakukan kesalahan yang sama. Karena memang sulit banget. Karena di result ini, saya sering menemukan result yang panjang, sangat panjang. Termasuk saya sendiri. Tetapi setelah membaca, reviewer itu masih bertanya, so what are the findings? Itu kan jengkel saya sebagai penulis. Jengkel pakai banget. Lu kan wis tak tulis gitu kan, sudah saya tulis itu resultnya. Kenapa reviewer masih tanya, so what are the findings gitu. Ini saya sharing aja ya Bapak Ibu. Jadi what are the findings? Jane ini reviewernya genah apa ora, dong apa enggak gitu ya. Tapi ternyata saya yang melakukan kesalahan, penulis yang melakukan kesalahan. Karena data kualitatif itu seperti sebuah tambang ya. Kita membawa batu dari tambang, Tapi pembaca tidak membutuhkan seluruh batu yang kita gali itu. Kita harus melakukan pemisahan. Kita harus melakukan penjajakan. Karena kalau kita di sebelah kiri kita lihat, itu di sebelah kiri punya banyak interview, banyak wawancara ya, banyak quotes yang bagus-bagus. Kemudian di proses analisis dan akhirnya kita mendapatkan beberapa tema utama, main theme-nya itu, maka the theme is the finding, temanya itu adalah finding, tapi quotes-nya adalah evidence. Jadi quotes bukan finding, quotes adalah evidence untuk memperkuat finding. Semoga bisa dipahami ya untuk teman-teman yang belum terbiasa dengan kualitatif. Jadi quotes itu menarik-menarik. Dr. Yusia sekarang ini sedang mengeksplorasi pengalaman pasien dan pengalaman dalam mempergunakan layanan geriatri di rumah sakit. Nah, itu macam-macam ya dan menarik-menarik. Ada yang bilang bahwa ya saya tidak akan spill di sini ya Dr. Yusia, nanti aja ketika SHP biar teman-teman oh wow gitu ya. Maka itu quotes-quotesnya itu bagus-bagus dan itu adalah bukan finding, quotes itu adalah bukti untuk memperkuat finding. Gitu. Quotes itu adalah hasil wawancara atau hasil kutipan wawancara partisipan dengan peneliti. Gitu. Nah, contohnya kalau misalnya tema kita adalah konflik moral antara profesional, tanggung jawab profesional dengan hambatan yang ada di institusi. Kemudian kita pilih satu atau dua kutipan yang benar-benar memperlihatkan konflik tersebut, jangan kemudian memberikan satu halaman penuh kutipan informan gitu. Jadi karena kutipan yang panjang itu tidak otomatis membuat result lebih kualitatif, enggak, justru kadang menunjukkan bahwa penulis itu belum selesai melakukan analisis. Jangan terus ditulis panjang-panjang ya, di sini ada mahasiswa yang sedang melakukan tesis. Jadi quote yang panjang-panjang itu enggak usah ditulis semua gitu. Kalau Bapak Ibu melihat satu kutipan sepanjang satu paragraf penuh dalam artikel, coba tanyakan, sebetulnya fungsi kutipan itu apa? Kalau jawabannya iya karena kutipannya bagus, ya hati-hati. Itu bukan finding, itu data untuk melengkapi finding, begitu ceritanya. Ya. Nah, oleh karena itu, kalau ada satu bagian yang saya minta Bapak Ibu untuk memberikan perhatian paling besar selain result, kita harus berhati-hati, tapi kalau perhatian yang paling besar harus dicurahkan pada discussion ini. Karena di sini sebenarnya kita menunjukkan bahwa kita bukan hanya pengumpul data. Bukan. Di sini ada finding, ini milik kita, di bawahnya ada teori. Jadi, ini sebetulnya adalah percakapan kita dengan ilmu pengetahuan yang sudah ada. Jadi, this is where the manuscript is accepted or rejected. Ya, jadi apakah finding ini ada finding, ada teori, kemudian kita gabungkan menjadi sebuah makna baru. Nah, makna baru ini menghasilkan kontribusi ataupun implikasi. Gitu ya. Sehingga kalau ini hilang dalam artikel kualitatif, konseptual kontribusi dan praktikal implikasi, ya sudah rejected. Sesimpel itu. Jadi kalau kita melihat bahwa contohnya kalau tadi saya bilang adanya moral distress pada perawat, pada pengalaman perawat karena limitasi resources di ICU, itu finding. Tapi diskusinya harus bergerak jauh. Apa artinya resource limitasi itu? Apa sekedar fasilitas atau menunjukkan adanya konflik antara professional moral obligation dengan organizational reality gitu. Nah, ketika kita mulai melihat hubungan tersebut, kita sedang menghasilkan meaning. Nah, menghubungkan dengan literatur ini, kita harus bertanya apakah temuan kita ini mendukung penelitian sebelumnya, atau berbeda, atau menentang, atau memperluas. Jadi, discussion ini bukan sekedar mengulang apa yang sudah ditemukan, tapi diskusi ini lebih pada menjelaskan hasil dan makna dari hasil yang kita hasilkan dan konseptual kontribusi gitu. Nah, ketika kemudian sampai pada konseptual kontribusi dan practical implication, ini adalah kita harus berbicara pada implikasi untuk tenaga kesehatan, untuk policy maker, dan ini lahir dari interpretasi. Jangan tiba-tiba memberikan 5 rekomendasi yang tidak punya hubungan dengan finding. Sering sekali mahasiswa atau peneliti itu ujuk-ujuk gitu ya, mak betunduk gitu. Tujuannya apa, diskusinya bagaimana, konklusinya bagaimana, tiba-tiba implikasinya mak betunduk gitu. Loh kok beda gitu ya, kok lain dengan yang tujuannya gitu. Maka your findings are the evidence. Jadi hasil-hasil Anda itu adalah bukti dan your discussion is the intellectual work. Jadi kalau findingnya itu adalah bukti bahwa Anda sudah melakukan penelitian dan hasilnya bagus, tapi your discussion itu adalah sebuah pekerjaan intelektual yang Anda lakukan. Jadi kalau discussion adalah jantung artikel, maka conclusion adalah suara terakhir yang tertinggal di kepala setelah pembaca menutup artikel. Oleh karena itu, pada conclusion ini sering diperlakukan seperti tempat untuk copy paste result. No. Jadi seringkali dituliskan the result showed, kemudian mengulang semua tema. No, big no. Karena conclusion bukan tempat untuk mengulang perjalanan yang sudah kita tulis. Conclusion adalah tempat untuk meninggalkan pesan. Saya ulang, conclusion bukan tempat untuk mengulang perjalanan, tapi conclusion adalah tempat untuk meninggalkan pesan. Jadi, kalau kita ngomong tentang conclusion, itu adalah seperti apa ya, pesan terakhir atau pesan kunci dari artikel ini untuk pembaca. Kalau pembaca mengingat satu hal dari artikel kita, maka kita bisa menjawab secara tegas bahwa kita akan memberikan direction forward dan apa yang harus dilakukan selanjutnya dan apa yang masih harus diteliti. Jadi, conclusion itu should not merely close the paper, it should close the argument. Ketika pembaca membaca conclusion, dia harusnya merasa, oke, saya ngerti sekarang kenapa penelitian ini penting. Gitu ya. Nah, kalau jadi saya sudah cerita per section, maka sekarang kita tarik semuanya menjadi satu bagian, satu blueprint. Jadi introduction itu adalah articulate the problem and lock the gap. Jadi kita mengatakan kepada pembaca, ini loh problemnya, ini loh masalahnya, and lock the gap. Ini yang belum kita pahami. Itu di introduction. Kalau di methodology itu adalah propose a specific way to address the gap. Ini loh cara kita menjawab yang belum Anda pahami tadi. Gitu. Dan resultnya adalah present evidence atau finding. Ini loh yang kita dapatkan setelah saya melakukan cara kita menjawabnya tadi pada metodologi. Di discussion kita build interpretation and contribution. Ini loh makna dan kontribusiku sebagai penulis. Dan di conclusion kita leave a take home message. Sekarang kita perhatikan garis yang menghubungkan semuanya, itulah red thread. Kalau saya menghapus satu bagian alurnya ini dan alurnya terasa terganggu, maka artikel Bapak Ibu belum siap untuk disubmit ke jurnal internasional. Gitu ya. Dan kalau Bapak Ibu ini merasa bahwa introduction kok kurang cocok sama conclusionnya, introduction kok nggak cocok sama discussionnya, tidak konsisten, maka siap-siap untuk rearrange si artikel ini sebelum kita submit. Nah, oleh karena itu saya ingin melakukan self audit. Apakah kita pernah melakukan kesalahan-kesalahan ini? Yang pertama adalah too much basic theory. Kadang introduction kita itu seperti buku teks, semua definisi dimasukkan, semua teori dimasukkan, itu juga terjadi pada saya. Solusinya pindahkan sebagian ke literatur review dan gunakan introduction untuk membangun problem dan gap. Ini semua orang yang sekolah, semua orang yang pernah menulis biasanya melakukan kesalahan yang sama. Semua teori dimasukkan di introduction, enggak perlu. Kedua, discussion repeats result. Jadi misalnya result mengatakan partisipan experience fear gitu ya, atau partisipan sangat ketakutan gitu. Nah, Di discussion dikatakan lagi, this study found that participants experience fear. Loh, lapo dibaleni rek gitu. Itu bukan discussion. Discussion itu harus menjawab apa sih yang penting dari hasil itu? Why does this matter? What does fear mean? What does it relate to existing literature? What does it contribute gitu. Itu yang harus dijawab. Discussion repeats result. Yang berikutnya adalah overquoting. Jadi interview quote itu biasanya sering terlalu panjang. Interview quote blocks are too long, overquoting. Jadi sering kali itu overquoting. Ditulis semua yang yang sama. Ditulis semua yang sama. Itu membuat pembaca itu bosan, atau sebelum ke pembaca ya, membuat reviewer itu jelek gitu ya. Ini jelek banget di bulan baleni dan banyak banget overquote-nya, quote-nya ditulis di sini gitu. Jadi memang benar bahwa kita membiarkan partisipan itu untuk berbicara, tapi let the writer itu interpret, bukan memindahkan verbatim ke artikel. Itu yang terjadi. Nah, yang keempat yang sering terjadi adalah the golden thread is broken. Artinya bahwa kita harus memastikan bahwa setiap bagian itu menjawab pertanyaan yang muncul dari bagian sebelumnya. Jadi sebelum submit artikel jangan hanya melakukan grammar check, lakukan juga narrative check. Ya. Nah, kalau kita masuk ke dalam kepala interviewer, bayangkan reviewer itu membuka manuskrip kita, dia tidak punya hubungan emosional dengan penelitian ini, dia tidak tahu betapa sulitnya kita mendapatkan informan yang sampai harus ke rumahnya, ditolak karena dikira ini dan itu gitu ya, dikira marketing lah, dikira apa gitu ya. Dia tidak tahu betapa malam-malam kita mengcoding data dan melakukan kategorisasi gitu. Reviewer cuma lihat manuskrip kita, titik. Maka yang ada di kepalanya reviewer adalah satu, why should I care about this topic? Kenapa topik ini penting? Yang kedua, what is truly new here? Apa sih yang baru dari artikel ini? Yang ketiga, what is the tangible contribution? Dan ini harus dijawab oleh discussion dan conclusion. So, do not make the reviewer work to discover your contribution. Jangan pernah membuat reviewer bingung menebak-nebak apa hebatnya penelitian kita. Kenapa saya harus peduli pada penelitian ini? Yang kedua, apa yang baru dari penelitian ini? Dan yang ketiga, apa tangible contribution-nya? Apa kontribusi yang nyata, yang tampak dari penelitian ini? Gitu. Nah, jangan membuat reviewer itu menebak-nebak apa hebatnya penelitian kita. Dan sekarang saya ingin setelah sampai pada gagasan utama dari seluruh presentasi kita, that a qualitative article is an argument. Manuskrip kita bukan passive report of observation, bukan sekedar ini yang dikatakan informan, ini yang kami temukan, ini tema 1, 2, 3 dan seterusnya. Manuskrip kita adalah sebuah academic argument. A qualitative article is an argument. This is the problem, tekankan kepada reviewer dan pembaca. This is the problem. This is what do we not yet understand. This is what we found. This is what it means and this is why it matters. Itu argumentasinya. Dan data gives us evidence, analysis gives us a meaning, narrative gives us coherence, and argument gives us contribution. Last but not least, saya ingin menutup dengan satu pemikiran sederhana, bahwa kita mungkin berpikir bahwa tugas kita sebagai peneliti adalah menemukan sesuatu yang benar, tapi setelah menemukan sesuatu yang benar, pekerjaan kita belum selesai, karena kita harus membantu orang lain memahami mengapa kebenaran itu penting. Harus diingat bahwa great author tell stories that change how we understand the world. Great writers tell stories that change the way we understand the world. Saya akhirkan. Terima kasih atas semua perhatiannya. Saya kembalikan ke Pak Aryo. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Terima kasih Dr. Tita. Selalu presentasinya menarik sekali. Sebagaimana peneliti kualitatif yang biasa bekerja dengan data dan merangkainya menjadi cerita yang sangat berarti, presentasinya Dr. Tita seperti biasa merangkai banyak data menjadi sebuah cerita yang jelas. Nah, saatnya sekarang kita masuk pada sesi berikutnya, yaitu discussion. Bu Tita, di sini sudah ada satu penanya, Dr. Andika, di chat room. Sementara saya masukkan dari pertanyaan yang Dr. Andika dulu, dan mungkin nanti berikutnya akan membuka pertanyaan bagi Bapak Ibu sekalian. Saya bacakan aja ya Dr. Tita ya.
Monggo Pak Aryo.
Baik, selamat siang Dr. Tita. Saat ini saya sedang merencanakan penelitian mengenai pengalaman caregiver pada pasien lansia dengan CKD stage 5 yang menjalani hemodialisis rutin. Mengingat caregiver burden sudah cukup banyak diteliti, saya ingin menggali aspek yang lebih mendalam seperti proses adaptasi caregiver, perubahan peran, strategi coping, serta bagaimana mereka memaknai perjalanan pengalaman mendampingi pasien dalam jangka panjang. Menurut dokter, bagaimana saya dapat mengidentifikasi knowledge gap dan merumuskan pertanyaan penelitian yang tepat agar penelitian ini tidak bersifat deskriptif, tapi juga memiliki keunikan dan konseptual contribution yang kuat sehingga memiliki potensi untuk dipublikasikan di jurnal bereputasi. Terima kasih.
Terima kasih, luar biasa pertanyaannya Dr. Andika ya. Saya terus terang kesulitan juga menjawabnya ini ya, karena begini, saya meyakini bahwa Dr. Andika sudah tahu jawabannya, karena caregiver burden itu berbeda-beda. Seperti tadi sleep disorder ya, sleep quality itu sebenarnya sudah banyak tulisannya, tapi ada yang pasti berbeda dengan sebelumnya, apalagi kalau ini dibuat seperti diteliti secara kualitatif. Nah, kalau ini diteliti secara kualitatif, rasanya tidak akan ada habisnya tentang caregiver burden ini. Menurut saya ya, saya sih belum terlalu membaca. Tapi bila kontribusi yang kuat dan memiliki keunikan dan kontribusi yang kuat itu tergantung dari tujuan penelitian kita. Tujuan penelitian kita ingin mengungkap apa gitu, tidak sekedar caregiver burden, tapi apakah Dr. Andika deep inside your heart itu, apakah Dr. Andika ingin melakukan sebuah langkah yang belum pernah dilakukan oleh orang lain. Contoh, saya bersama mahasiswa S1 dan PPD SIPD sebelumnya itu mengungkap tentang stres, betapa stresnya para lansia ini di panti jompo, gitu ya, di panti jompo. Mestinya sudah banyak gitu ya, sudah banyak sekali yang bisa diangkat sebagai topik untuk panti jompo lansia di panti jompo ini. Tapi ada hal-hal yang spesifik gitu, seperti kalau yang anak S1 ini kepada pramuruktinya itu bisa dilatih oleh dokter umum atau dokter spesialis geriatri penyakit dalam yang untuk melatih setidaknya Nancy yang benar gitu ya, posisinya harus benar. Kalau ada orang begini gitu ya. Jadi khusus untuk pramurukti itu ada implikasinya atau kontribusinya. Nah, sekarang kalau dengan melihat atau mengeksplorasi caregiver, sebetulnya Dr. Andika pengen memberikan kontribusi kepada siapa? Kepada caregiver, kepada dokter spesialis penyakit dalam, kepada dokter spesialis penyakit dalam yang geriatri, atau kepada pemerintah. Nah, itu kita lihat di situ sih sebetulnya, Dok. Untuk melihat perubahan peran pasti sudah ada penulisannya. Wong kita ini, bumi ini sudah sekian juta tahun umurnya, pasti tidak ada penelitian yang belum pernah dilakukan gitu ya. Pasti semuanya pernah dilakukan. Cuman ada satu saja yang unik, itu bisa membuat tesis artikel kita itu diterima atau tidak. Contoh yang saya lakukan saat ini adalah penelitian tentang Carok tentang carok itu ya, menarik itu carok, dan itu carok itu sudah terjadi mungkin puluhan atau ratusan tahun yang lalu gitu. Tapi ketika kita mengangkatnya ke artikel internasional itu menjadi menarik gitu ya, karena tidak ada di tempat lain. Mungkin di Amerika ada itu, yang tapi yang apa namanya, saling membelakangi terus maju 3 langkah terus bedil-bedilan semacam itu ya. Carok juga semacam itu. Nah, itu punya karakteristik sendiri. Pernikahan dini yang pernah saya lakukan, saya juga sedang submit dan sekarang ada review. Itu pernikahan dini itu sudah praktik puluhan tahun di Indonesia, ratusan tahun bahkan gitu ya. Dan di Madura itu yang termuda adalah 9 tahun. Itu menarik sekali ketika saya presentasi poster presentation itu menjadi pusat perhatian dari para juri gitu, karena ya terus kontribusimu apa gitu. Saya bilang bahwa budaya ini harus didekati dari tokoh agama gitu. Kalau tokoh agamanya itu tidak mengiyakan praktik pernikahan dini ini, maka tidak akan ada gitu. Jadi kita harus tahu dulu, Dok, apa yang ingin kita berikan, kontribusi apa yang kita berikan kepada siapa, itu kemudian kita giring untuk datanya itu disesuaikan dengan itu gitu ya. Bukan kita manipulasi, tapi kita boleh memilih tema-tema yang sesuai dengan kontribusi yang kita harapkan. Gitu, kira-kira begitu, Dokter. Jadi mungkin tidak bisa menjawab sepenuhnya, tapi setidaknya kalau di dalam beda ya meneliti dan menulis ya. Kalau meneliti kita tujuannya satu, dapatnya bisa banyak. Kalau menulis tidak, kita mau menulis di mana, biasanya jurnal itu tujuannya apa, dan bagaimana selingkungnya, kita sesuaikan hasil-hasil mana yang bisa mencapai dari tujuan dari jurnal ini. Mungkin itu sih jawaban saya, semoga menjawab sedikit, Dr. Andika.
Terima kasih Dr. Rita. Dr. Andika bagaimana? Apakah sudah menjawab? Matur nuwun. Terima kasih Dr. Andika sudah direspon, Bu Tita sudah menjawab. Berikutnya tadi ada yang raise hand. Ini siapa ya? Dr. Nita ya? Atau ada pertanyaan yang lain Bapak Ibu?
Sekedar menambahkan informasi Pak Aryo bahwa menulis penelitian kualitatif itu susah tapi seneng susah. Jadi senangnya lebih banyak daripada kalau saya itu seneng susah, karena saya sebetulnya kan juga peneliti kuantitatif juga bisa gitu ya. Tapi ketika membawa hasil penelitian kuantitatif ini ke dalam sebuah jurnal, itu menurut saya itu, bagi saya sendiri itu kurang meaningful, kurang maknyes gitu. kurang apa ya, kalau di kualitatif itu banyak sekali yang bisa kita ungkapkan dan bisa menjadi beberapa artikel. Ketika kita melakukan satu penelitian itu bisa mensubmit beberapa artikel, seperti Bu Indah di mahasiswa S3 datang, ada nggak ya, itu bahkan dalam satu penelitian itu bisa jadi 3 artikel. Itu luar biasa kalau penelitian kualitatif. Begitu Pak Aryo, informasi yang bisa saya tambahkan.
Terima kasih Dr. Rita. Tampaknya masih belum ada pertanyaan lagi Bapak Ibu. Ya, Dr. Rita, mungkin dari jawaban Dr. Rita tadi yang di awal, bahwa sebetulnya kalau memang kita sedang meneliti kualitatif dan membayangkan kontribusi apa, sehingga konseptual kontribusi apa yang akan bisa menarik untuk dipublikasikan, itu bisa saja dari awal kita rencanakan ya Bu Tita. Tapi Dr. Rita juga menyampaikan bahwa sebetulnya dalam konteks yang berbeda, dalam cerita yang unik, itu selalu ada potensi-potensi publikasi. Seperti yang disampaikan tadi, ada carok yang mungkin fenomenanya sama dengan duel koboi itu tadi yang disampaikan Bu Tita. Tapi ini sesuatu yang berbeda, mungkin alasannya berbeda atau hal-hal lain yang berbeda, dan itu mungkin menarik bagi dunia internasional untuk dibahas gitu ya kita. Lalu ada juga fenomena pernikahan dini yang mungkin tidak pernah terbayangkan di dunia gitu ya. Oh, ada sesuatu yang terjadi seperti ini. Jadi ada yang bisa direncanakan dan ada yang muncul nanti dari data. Begitu mungkin Bu Tita ya.
Iya, betul.
Ada pertanyaan Bapak Ibu yang mungkin Bapak Ibu sedang sekarang menulis artikel atau sedang penelitian kualitatif bisa disampaikan di sini. Sepertinya sudah sangat jelas ini Bu Tita.
14.
Jadi terima kasih Bapak Ibu. Kalau memang tidak ada pertanyaan apa kita tutup Bu Tita?
Nggih, monggo Pak Aryo.
Oke. Jadi terima kasih Bapak Ibu telah mengikuti sesi demi sesi. Ada 2 sesi hari ini dari Dr. Eva dan Dr. Tita. Dan hari ini kita sudah sampai pada sesi yang terakhir. Saya menyampaikan terima kasih pada Bu Tita telah mengalokasikan waktu dan mencurahkan energinya untuk menyiapkan presentasi ini. Pengalaman yang disampaikan sangat menarik dan sangat bermanfaat bagi kita untuk mengikuti langkah yang dilakukan oleh Dr. Tita. Saya kira cukup demikian Dr. Tita. Terima kasih sekali lagi. Terima kasih Bapak Ibu partisipan pada sesi workshop kali ini. Dan ada pesan dari Dr. Sri Sunarti bahwa penutupan langsung dari moderator, dan oleh karena itu saya sekaligus moderator sekaligus menutup acara workshop pada hari ini. Sekali lagi terima kasih, mohon maaf, sampai berjumpa lagi pada kesempatan yang lain. Terima kasih, wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih Pak Aryo, Dr. Sri.
Tenun, Bu Tita. Saya mohon izin live ya.